So good morning, ladies and gentlemen. It has gone 10 o'clock. We are the Staffordshire County Council Health and Care Overview and Scrutiny Committee. I'm your chair, Councillor Jeremy Pert. I'm going to restrict my comments this morning to being very, very brief, given the size of the agenda. And so I'd like to welcome councillors and our guests. I'm going to remind our guests at every opportunity that we have 5 items on the agenda. We have a maximum of 3 hours because we will finish on time. So to ensure that we are robust in our questioning and scrutiny, I would ask our presenters to limit their comments to no more than 5 minutes, accepting that members will have read the paperwork. And if there are things that we need to come back and scrutinise in more detail, then we can take those decisions as we come. So, good morning. Let me just remind committee that today's meeting is being broadcast live and for those who want to watch it back, they can find the recordings on the County Council's website. And the current setup is that the recording will cut off 20 seconds after the equipment has stopped. All voting committee members are in person, and there is a variety of in-person and virtual attendees as our guests. And as I say, if we can restrict our comments to opening comments to 5 minutes, I would be grateful, please. So let me move on to the agenda for this morning. First of all, apologies. Zach.
Good morning, Chairman. I've received apologies from Councillor Chapman, Councillor Jones, Councillor Leung and Councillor Hewitt.
Thank you. And obviously, for those of us who are aware of Councillor Hewitt's reasons for being absent, we obviously wish him our best today and look forward to seeing him back in this chamber in no time at all. Thank you. So, declarations of interest. This is a standing item. Ladies first, Bernard, if that's okay. So, County Councillor Anne Angela.
Good morning, everyone. Yes, I'd like to declare an interest to be partner governor on the Midland Partnership University Foundation Trust from the County Council. Understood.
Thank you, Councillor Bernard Peters.
Local authority appointed governor at UHDB.
Thank you. Any other declarations of interest in relation to this morning's items? No, I will carry on then. So that brings me on to the minutes of the meeting of the 12th of June. That was the first one we've done in this new municipal year. So do we have any comments, any questions? Are we happy with the accuracy of those minutes? For those of us who are there, yeah, I'm getting a few nods. I'm reliably informed that the actions have been logged as part of a log, and we will start seeing the log, but everything that we have has been circulated back to members. So are we happy to approve those minutes? Okay, that's unanimous. I will sign those as we go. And that takes us on to item number 4. We've already gained 6 minutes, Zach. That's good news. So the Integrated Care Partnership Operating Plan. So, Paul, we are with you. Do you want to open your comments? We have read the papers in detail. And can we give you 5 minutes, please?
Yes, thank you, Chair. Thanks for inviting me back. I just wanted to briefly introduce the paper, really, because when I joined you last time, one of the key comments you made to me was that we wanted to see more kind of join between the plan and other parts of the system, and we've aimed to do that, so be interested in your feedback. I don't, as you said, I don't need to go through the papers particularly, but perhaps just draw your attention to page 23 of your packs, 23 of the 152 pack. That's what we call our system triangle. This was created by system partners working together. So this wasn't just a health creation; it was health and social care construct. We had a session back in February, on February the 13th, I think it was, where we all came together and agreed the need to have some greater prioritisation of what we need to do, because there's just so many things that we need to do. And we agreed on a single collective aim, which was to focus in on the Category 2 and Category 3 ambulance waits, and to improve that, because we were concerned, I think, coming out of the winter, that we were causing harm to people who were needing support at that time, and we felt that if we concentrated on that single aim, we can make a difference, because all of us contribute to the patient the person who ultimately needs to dial for support. So that is the top of the triangle, one collective aim, which we agreed. We then agreed under that we need to have some greater focus around the priorities. So we came down with the 4 that you see here. So focusing in on urgent care, tackling the backlog, the general practice wait, and focusing in on complex individuals. And Chair, you made the point that these were things that were particularly important to local people. So we did listen to that, and hopefully we've reflected that in the plan. Then under that, we do have a wide range, and this is now into sort of an NHS world, I suppose, of requirements that were set by NHS England. So 31 national objectives that were set. So all of those have to be addressed, but we didn't so much deprioritise them, but we wanted to make sure that we focused from those, the ones that were going to be most impactful. So all 31 though are reflected, and that results in 50 national actions that we've been set. Really the key then is under that the collective effort, so really working together. The portfolios, you're familiar with that now, I think, so 7 portfolios that we have working across the system. We have the combination then of the 3 in-system trusts, the 2 partner trusts, that's UHDB and RWT, who are particularly important to our system in terms of flows. The 2 upper tier local authorities, this one, of course, and the City Council, working across the 2 places, trying to create one provider collaborative working across, which encompasses not just providers, but also the voluntary third sector organisations, all underpinned by a public population health model, and then the People's Assembly. So really, I wanted just to focus in on that. I think in my 5 minutes, that's probably all I've got time to say. The information in the papers go through all of that in more detail. There's a focus in on the 2 kind of key areas that we needed to make a change, which is around emission avoidance and discharge. We had another very helpful conversation a couple of weeks back. We had Richard Harling from yourselves, and your new chief executive Pat was there. Really helpful conversation where we've focusing down on what this actually means, what we actually need to do to make a difference to the population, so that we do avoid the emissions in the first place, and for those who are admitted, that the discharge process works more effectively, and we have more of those people who come through the discharge process going back home, as opposed to going on to CHC or social care support. I think probably in the time I've got, Chair, I'll stop there and obviously take any questions yourself and members have.
Thank you, Paul. I'm going to throw open the floor to questions on the operational plan. Janice.
Find the right button there. Thank you very much, Chair. Good morning. It was a couple of things, really, as we're looking through the plan. One curious question that I've got, when we start looking at the frailty side, and we've got the placemat plan, that there was no national objectives. And I was just curious as to the reasoning behind that. And then the other one that I did have a specific question about, and certainly one that residents have been in touch with myself in regards to, is autism diagnosis. And there is a reference, I'm not sure if it's supposed to say Black County adults or if that should be Black Country adults, if we could just clarify that one. But how it's looking with regards to those waiting times. I understand that this is the plan, but as I say, at one point I was getting more emails to do with such matters as opposed to potholes, just to give you a bit of context. Thank you.
Now, there's a surprising comment. Never thought I'd hear that in my time in the County Council. Paul, there's a challenge for you, I think.
Yeah, so both good points. I mean, the frailty point absolutely is central to what we're working on in terms of particularly our emission avoidance, because we know that there's a high uptake of healthcare for people, particularly over 75s with frailty, and we don't think that acute emission was always the best solution for those people. So good point around the sort of perhaps not getting that degree of focus at a national agenda that probably should be, but certainly locally it's kind of top of shop for us in terms of our focus. I can give assurance on that. In terms of autism, the same. Yes, good spot on the typo. Absolutely should be Black Country. So apologies for that. Again, it's a huge. Yeah, we have put it down at that level of the 31 priorities, but it's within that that level, and it's very much part of the focus of the work of those portfolios. That one fits within the mental health and learning disabilities portfolio, and autism access and diagnosis is you're right, is a huge pressure point, increasing demand, and we are trying to respond to that, but clearly difficult given the uptake of volume of requests for the support and diagnosis, and again within constrained finances. But we are absolutely working on that particular area.
Janice, do you want to come back?
No specific follow-up in regards to those. Obviously, we'll watch, that information as it comes through, but just to, sort of take some time to reflect on how much detail is actually in this report, and it's useful to be able to see it all documented, is the only other part that I would say. Thank you.
So can I just pick up a couple of things, one for Paul and one for you, Janice? Do you want to think, and this is for committee overall, is there a different way of scrutinising this and breaking it apart and getting into some more of the detail? And is that really something we should be doing or feel we'd find some benefit from doing? Maybe that's a question for everyone in this chamber, bearing in mind that there's probably lots of substrands and linkages and lots of other things in here. Don't want to create work given we've got a fairly active agenda, but I just do want to make sure that if the ship is pointing in a direction but it's the wrong direction, and we haven't spent any time looking at it, that might just be a concern for members. So that's one for committee. Paul, can I just come back to what you talked about in terms of frailty and what this what the strategy looks at? One of my biggest concerns is not listening to the patient's voice. And the patient says, I don't want to go somewhere. Have we closed some of these loops and gaps in terms of data sharing and ensuring that the ambulance service has the same vision and view of the patient, as does the voluntary sector, as does the GP primary care, as does acute care, and that would, in my view, in terms of frailty, be a big step forward.
Chair, I think you're absolutely spot on with that, and it's a point that we're absolutely aware of. I can't give you assurance that we've cracked that one yet at all. In the sense, one of the more distressing indicators is that 45% of our residents die in hospital, and for sure that's not what they ask of us. So we haven't yet solved that one at all, but it's very much, again, to give you where I can give you assurances is we're absolutely onto that, and the empowering the resident, the patient to be able to determine what they want from the health system, social care system is absolutely what we need to do. And you're quite right in your question in terms of that interface between health and social care and the ambulance provider, and having that information available at the point that the person needs support is where we need to work. Clearly a massively complex and tricky thing to achieve, but this is where we can get greater alignment of what the patient needs, and also make it better, and also frankly less costly, because we're actually often incurring we're putting patients through the wrong pathway, the pathway they didn't want to go, and at the same time incurring more cost. So we are trying to look at ways of how to work more through a collaborative way across that whole pathway, so that we put the patient voice at the heart, and in so doing we provide a better patient pathway and indeed a better financial result as well. So as I say, your question is spot on. But clearly a very complex and tricky one to fix.
I understand, thank you. No doubt we'll come back to it over the course of ensuing months. Charlotte Atkins.
I'd like to drill down into some of the detail, because I think to some extent this is more of a sort of a wish list rather than a delivery list. And for instance, to take one example, on page 25, you talk about to deliver the recovery of dental activity, that's to pre-pandemic levels. How exactly are you going to do that? I mean, the issue is that we have a national contract which is not working. We have a shortage of dentists, and we have, 9 in 10 people not being able to get hold of an NHS dentist. So how exactly are you going to deliver that? The second question I want to ask about is about the rollout of diagnostic centres to deliver 20% more diagnostic test activity. What's happening with that? Where will they be? And I see that nowhere within the document do we mention integrated care hubs. Have they slipped off the agenda? Are they old news? Or are they still going ahead? Because I think this committee has a subcommittee looking at integrated care hubs, but nowhere is it ever mentioned nowadays. I appreciate the government has thrown a spanner in the works in terms of requiring bids for capital monies. But, why have we not been told if these are no longer part of the agenda? And if they are part of the agenda, why aren't they mentioned in this plan? So I'd like to start with those. Thank you.
Thank you, Charlotte. Paul, we're with you. Some meaty subjects there as well.
Yes, thank you, Charlotte. Yes, so the dental uptake, you're quite right. I mean, it is extremely difficult to deliver what we're looking to deliver because of the dental contract, which is outside of obviously our control. But we are working across we're particularly working within the West Midlands now, but it is a regional effort, but we're particularly working within the West Midlands because now that the responsibility for commissioning dental services now rests with us as the ICB. Previously, that was a responsibility of NHS England. So that is helpful that it's been brought more local, but we are working across West Midlands in terms of agreeing an investment approach, putting in more capacity. But that is our intent. But again, your question, I'm afraid, is right. It is difficult to do that when dentists don't necessarily want to work under the current contracts. So we are constrained, but we are doing everything we can to increase uptake because it's just provision, because the level of NHS provision is woefully inadequate. The second question about rollout of diagnostic centres, yes, that is progressing reasonably well. So the three, and Tracy will correct me if I've got any of these locations wrong, but the three locations in Staffordshire are one within Stoke itself, one within Tamworth, and one at Cannock, and all three are going ahead. I mean, they aren't yet in place, but we are going through the process of agreeing the capital with the region, the national team, and all three, it looks promising. And there are logistical challenges with all three in terms of exactly where and how to construct the additional facility, but all three look like they're going to progress and going to result in the extra capacity we need in order to meet that 20% target that you refer to. In terms of the integrated hubs, now they are also progressing. At the moment, they're with Midlands Partnership Foundation Trust, who are going through the business case process. The reason they're not mentioned in the operating plan is that reason, because we're currently developing the business cases. We're quite close now to completing the outline business case for the integrated hubs. Once we've got to that place and we're clear on the exact site, well, we know the siting actually, but the exact construction of the facilities, what we need and how they're going to work, at that point we will then be going back to the centre to request the capital increase to our limits that we'll need in order to make those changes. As I think you probably will know, and I guess most members will be aware, when we went through the process previously and agreed that we needed to develop these integrated care hubs, we agreed that capital will be found from within the Midlands Partnership Foundation Trust to have the cash reserves. Since then, the capital regime has changed, so we're not entirely sure what will happen once we go back to the centre and request the go-ahead, but we will do that once we're clear on exactly what the business case requires, and we'll keep this this committee up to date with how that progresses, and we may need to have further conversations around how to free up the capital. But at this stage, at this stage, that's not a constraint because we're still going through the business case process.
Let me come back on those two issues. First of all, I mean, one of my criticisms of this report is the lack of timelines. And also, you know, to say that with dental activity that you want to get back to pre-pandemic levels, well, that certainly lacks ambition, because before the pandemic, dentistry situation was dire. It is now in crisis. So to go back to dire from crisis is hardly ambitious. And it appears from your comments that there is no plan, no realistic plan to actually do anything about it. So I think that, you know, to put that in the operating plan as if somehow it's going to happen, it's more of a wish list. And secondly, you know, what worries me about what you've said about the integrated care hubs is that if we haven't even yet got the business case sorted, how many years are we talking about before anything starts being built or designed on the ground? Are we talking 2, 3, 4, 5 years? What's your idea? Because at the moment, you know, within this operating plan, there's very little in terms of timelines. So let's give us some sort of idea about what the timelines are. I mean, I realise that this is with the Winters Partnership, but this is supposed to be the Integrated Care Board that's supposed to be able to tell us what's happening right across the NHS, and to sort of say somehow the ICBs are all about Midlands Partnership seems to me that the integrated care system is not working in an integrated way.
Paul, we're with you. I've got some information, but I would prefer you to answer first, because I'm not here to offer answers to scrutiny. I'm more here to support. So
yeah.
I'll leave that with you, and then hopefully I might fill in some gaps if there are any, Paul.
Okay, thanks, Chair. Well, yes, I don't accept that we're not operating the integrated way. Actually, I don't think that's the case. What I was trying to explain was that in delivering the integrated care hubs, we as a system have asked MPFT as the organisation to be the one that fronts the development of the business cases, which obviously involve the whole system. They involve, primary care, community care. So it is an integrated solution that we're developing. The point about the timeline, I guess I can kind of see where you're coming from, Charlotte. I mean, this is an operating plan for 23-24. In 23-24, we will not be building integrated care hubs. They will not be on the ground. So perhaps right. We perhaps should have been clear in terms of the work that is going on in the development of the business cases. Until those business cases are complete, I can't answer your question in terms of the exact point at which the buildings will come into fruition. But I mean, clearly, Chair, we could have a separate conversation around that, and colleagues from MPFT, I'm sure, will be happy to come here and give further detail on exactly how the business cases are developing. But yeah, they will be complete. The date for the completion of business cases is fairly soon, within I think a few months. So at that point, clearly those questions can be addressed. Just quickly on the dental one. Yeah, I think it's more than a wish list. I think if that's an area of priority for this committee, then I'd suggest a deep dive into dental services would be helpful, and there are individuals within our organisation who can provide much more detail than me. I'm sorry if I haven't given enough detail to that. But again, it's a hugely complex area and requires probably a half-hour conversation on its own if that's an area of priority that you want to focus in on.
Thank you, Paul. And I think you pick up the last point accurately, in as much as the last committee we talked and focused in on dental, albeit it's very early days for the ICS in terms of taking over the responsibility for dentistry within the area, and it is coming back to committee in November.
Okay.
Albeit, I also note that we were ahead of the national news on this, which is always a good news position to be in, but clearly not good enough news for our residents, because there is a shortage of dentistry locally. But I think without understanding capacity and the shortage of the gaps in capacity in which areas, and without you coming back with a plan, not you, but the integrated care system coming back with a plan which is scheduled for November, then I think that we're probably without that piece of detail, both you and us. Just in terms of the integrated care hub, and I stand to be corrected elected by the chair of that working group. But my understanding is that the outline strategic business case is being completed in July, and that will then move into a full business case in March, and that shortly after, is it in August, there is a plan to get that working group back up and running, which includes yourself, I think, Councillor Atkins.
Sadly, it no longer includes myself.
I'm sure anything could be possible.
It appears I'm not a member of the committee anymore, and because I'm a cabinet member, so I think that's why I've been ruled out, according to Zach.
Okay, thank you for that. I don't want to sort of use committee time just for that, but maybe what we could do is find a way of ensuring that you're fully briefed and we are able to take your input to some really important decisions and discussions within your area. So if you're happy, we'll take that offline and just find a way to keep that going. Bernard, with you.
Thank you, Chair. Primary care and the work of the GP and the model going forward, I've been looking for the role of the pharmacist. The pharmacy was a drumbeat message that started off the new model of care regarding GP support to the community. So is it moving at pace? Is it started? What can we expect to see in the medium to short term regarding the role of the pharmacist supporting the community?
Paul, we're with you.
Okay. I'm not an expert on that particular subject. All I can say is that pharmacy is very, very much front and centre of the plans for primary care. The additional roles that we've invested in, I think we're up to about 500 now, additional roles that we have across our primary care networks. A large number of those are pharmacists. We are having conversations about kind of joining all that together into an overall pharmaceutical solution. I mentioned a bit ago the conversation that we had a couple of weeks back, a system conversation. One of the key themes on that conversation was on medicines and creating a system approach to medicines and joining pharmaceutical together across the system in a much more in a much stronger way, and linking from primary care, where Bernard, you're absolutely right, where it's absolutely crucial, but linking that through to decisions that are made on pharmaceutical decisions that are made by secondary care clinicians and joining it all together so that we get a seamless pathway in terms of the drugs that are prescribed to patients. So, a lot is going on pharmacy. Again, I'm not an expert on pharmaceuticals, so we could obviously bring an expert along if you wanted to go any deeper than that, but hopefully that's enough assurance that it is absolutely part of our current planning process.
Can I just, before I come back to you, Bernard, can I just bring in Baz? Are you on this pharmacy, please?
Yeah, I just wanted to add some comments there, because most of the feedback we get from the patients at Healthwatch is usually around access, especially around primary care, being GPs and dentistry. One of the ways we're trying to support the system, from our perspective, is working with the ICSs as well, is when patients are calling us in to help find those pharmacies that are attached to the GP practices. And what we are finding is that those pharmacies, and we can help sometimes, given capacity to arrange those appointments. So it means that the patients don't have to necessarily, in their terms, battle with the receptionist or the phone line trying to get that 8 o'clock rush. They can actually go to the pharmacies to get the medication for their family members. What we have found is that has helped alleviate some of those pressures. So I just wanted to add a little bit of a comment around the way we're offering the information, advice and guidance to support this idea. That is helpful.
Sorry, I should have introduced Baz a bit more effectively, because Baz is the lead at Healthwatch, which is just another feed of information into our residents across Staffordshire and Stoke-on-Trent, and hence he's a non-voting member of this committee. But for members who aren't aware of that, just important to put in place why Baz is with us and why sometimes I might bring him in specially, because I think it just adds to the debate that we're going. But Bernard, do you want to come back? And is there a thought that maybe Healthwatch could be doing some more work if there is a new model for access into healthcare through primary care and through using the wider range of community pharmacists? Is there something else we could be doing in this respect?
Yeah, thank you, Baz. That was really helpful, your comment. I just wondered if there's I'm putting it in the context of pace, because the model, the GP model is incredibly overburdened at the moment, and the pharmacists have got a role to play. But I don't get a sense that there's any particular motion behind it to make it happen quicker, to play a bigger part. So if there's any chance of bringing a bit more pace to it, I think the community would welcome that.
Can I come back in on that one, if that's all right?
Can I bring in just Tracy Sewan for a minute and then bring you back and then maybe go back to Paul? I know that sounds a bit convoluted. So, Tracy, we're with you first, then we'll come back to Baz, and then we'll try and square this loop.
Yes, I think if you see in the pack, there is something around access to community pharmacist consultation and quarter 1, 2, 3 and 4 numbers that we've actually put in on the plan. That's on your medicines optimisation page. But the other thing I wanted to mention is, and thank you to Baz from Healthwatch as well, is the engagement that we need to do with the community and the education work. Especially around pharmacists and access to pharmacists, and the fact that also in general practice you could be signposted to see an advanced nurse practitioner, a physiotherapist. There are pharmacists working in general practice. All these roles are there to support access and actually to get you to the right person at the first time. But there's a big piece of work going on. It's already started with the community to actually help people understand those roles, because sometimes I think they feel they're a bit tricky, maybe being fobbed off, which is absolutely not the case. It's actually getting you to the right place at the first time. So I just wanted to add that.
Thank you, Tracy, and good morning. Baz, do you want to add anything further, and then I'll go back to...
Yeah, I just want to say and echo what Tracy said. There are new roles coming out to support the idea of how to get your needs met rather than just calling a GP, because there's quite a lot of people that do tend to call in that actually can have their needs met outside of just calling a GP practice. So we're just trying to understand from a Healthwatch perspective, because we are doing a deep dive into primary care and access into primary care, and that's including face-to-face, because there's still this idea that a lot of patients want face-to-face. So if there's going to be this push for these new roles coming out, it's just a case of how we can help support that idea with the residents out there to understand that there's more than one way than just to pick up a phone call and call the GP.
Thank you, that's useful. We'll come back to that in a minute, I'm sure. Paul, do you want to come back in on anything, or shall I just leave the final word with Bernard?
Well, I think helpful comments, and I'll take those back to our primary care team. But I absolutely share the need for pace, and this is a big opportunity, isn't it, to give patients a different ways of getting the support they need, rather than necessarily going straight to the GP. So thank you for the comments.
Thank you, Bernard. Is there anything else you want to add?
No, thank you, Chair. I'm comfortable with the responses so far, and I look forward to further evolving process, really.
And the only question that sort of lingers in my mind is whether there's just a discussion that we might benefit from having a number of us with Healthwatch, just to make sure that the work they're doing in this area ties into something that we might want to come back to later on in the next 6 or 9 months. Because obviously if they're scoping some work, it'd be useful just to make sure that their scope is in line with something we might benefit from.
Yes, we want to make sure it's aligning perhaps with anything you have in mind, Chair. So I think we'd welcome that, yeah.
Yeah, so I think you're putting your hand up. I'd be more than happy to put my hand up. Is there anyone else in this chamber who'd be happy to join some of that scoping work? Yeah. I've seen, can you just note these for me? Jill, Anne, Bernard, myself, and Keith. Keith? Yeah, Keith. And I think that's more than plenty. Okay, right, let's get back on track. Sorry. Anne, we're with you.
Thank you very much, and good morning, Paul, and thank you for your presentation. And my question relates to children and autism services. I'm pleased to read that the physical health and mental health are being treated equally. What concerns me, how do we know we're giving our children with learning disabilities and autism that right kind of help? Schools, as we all know, are run by local authorities, academies, but specialist schools are operated by private providers. Is there any check made that that they're offering the right kind of help for our children? I ask that question in light of cases that have come to my in my position as a counsellor. I beg of you all, for all the parents and children out there that's got problems, and I'm talking for all parents in Staffordshire, I beg of you to ensure we pick children up at a nursery stage if they're found to be suffering from any early stages of mental health, be it autism and ADHD to start with, to start work with them at that very young age. I really appreciate it if you could look into that, and, you know, it's so important. Thank you.
Paul, we're with you.
Yeah, morning, Anne, and thank you for that. And yeah, personally, absolutely share that. I think many of us do. And just to give you hopefully some reassurance, I've mentioned a couple of times now the system event that we had a couple of weeks back, and one of the 6 things we focused in on was children and children's services generally, and children mental health services. And I'm really pleased that we did that, because I think often we focus in, as we have to, on the urgent care, on ambulances, on waiting lists and primary care, but we actually gave focus to children and mental health for, I think, probably for the first time, and it was a really powerful. So one of the 6 tables focused in on children's services and mental health services for children. One of the key actions coming out of that table was the need to create a single kind of register of children who are in the have requirements for healthcare, mental health, or otherwise. And it might kind of sound like an obvious one, but it's not there at the moment. And so we're constantly surprised as children get passed from parts of the system to another part of the system. So it was just, perhaps you might say, a small step, but I think actually a big step forward in terms of that joined up way of working for this really important area. And unfortunately, we know that it's increasing in demand, isn't it? I mean, earlier question referenced autism services, but more generally, children in need, requiring placements, etc., is on the increase, and it's something we need to work on together. And yes, we absolutely are. And as I said, I'm pleased to be able to report that it is been given real priority within the system.
Anne?
Thank you for that, Paul. You know, we'll have to keep our eye on it, because I want to make sure that we do give those children that help when they need it right at the beginning. Because the thing, when you get to teenage years, you've lost them. You know, you've got to be, yeah. Can you just explain to me what the mandatory training, the Oliver McGowan training is, and how does that operate, please?
Yeah, again, I'm not. Oh, Tracy got a hand up. She could probably give a better answer than me, to be honest. I could give Tracy.
Okay. Oliver McGowan was a young gentleman with autism. He was high functioning, and his mother campaigned tirelessly after his tragic death to implement what we call the Oliver McGowan training across NHS providers. It's the online training that we do, and we've got some workforce specialists on the call with us as well this morning. But the online training that certainly we've done, it's very powerful. It's a real powerful tool to how you work with people with autism, with children with autism, especially in physical health, and how their needs are met. And if anybody watched the ICB board on, and thank Councillor Edgeler, thank you for coming. On Thursday last week, there was quite a powerful presentation from a young lady about her communication needs. So it's very much along that track, Councillor.
Thank you.
Brilliant. Obviously, if you want a further question on that, it maybe is relevant for later in the agenda on the people agenda piece, but just in the interests of getting through everyone. Keith.
Thank you, Chair. Thanks again for the presentation. My question really is about the work that myself and most of the members here have been doing for a very long time within the community, trying to support people and prevent them from getting into hospital treatment and all the rest of it, or even wanting primary care access and everything else to quite a number of times through their lives. I noticed within the plan that there's an idea of independent living for longer and all the rest of it. However, I don't see that necessarily in the system plan on page 23, which you referred to earlier. It doesn't seem to be necessarily written into that. That seems to be very much hospital-based, and all the I can understand that. I can understand that that's a priority listing at the moment. My concern is that as a strategy, this isn't going to necessarily lead to less people coming into the system over the coming years. I'm not trying to criticise this at all, because I know this is where you've got to concentrate on. And on page 48 and 65, there's quite a lot of information there about working with people and communities and things like that. I just think there needs to be a fresh approach to some of this. I just think that if you don't bring the population, if you don't bring communities with you on this new strategy, on this new path, then even when you do improve dental services or primary or access through pharmacies and things like that, people won't necessarily react to your plans in the way that you may want them to. And certainly I would like to see less pressure at emergency care and all these other things. These are the things that you have put quite high up on your priority list, urgent and emergency care and everything else. So that's why if you can understand why I'm concerned that it's not necessarily higher up on the agenda. So I just wanted you to come back from that one. There's a thing to do with training as well, bringing people along, looking at how your concepts can be presented to a population and the community, perhaps through people like councillors and ourselves, which is why we're involved in this committee in the first place. And my only last comment is nothing to do with you, if you can answer to those. It just says that on the report itself, on the committee, it says community impact, nil. I was hoping that there would be some community impact on this occasion, because otherwise there's no point in looking at it from that perspective. But anyway, I hope you get the idea of the question anyway. Thank you.
Paul, just because I know that we're limited in terms of time and we've still got another agenda item and I've still got one more questioner as well to bring in. Maybe we could just do, if you could pick up the first about housing, which is critical for the districts and boroughs, and I think it's a really important point. I think, Keith, if you ask the second question again later on in relating to people, item number 8, that would be helpful. And in terms of the community impact statement, I think it was because effectively the NHS have provided the integrated care plan alongside their partners, and it's a county council requirement to do the community impact assessments. So let's just focus on the first one, Paul.
Okay, thank you, Chair. Thank you, Keith, for that question. Again, you're absolutely right. Of course, the whole sort of avoidance of admission is kind of the key thing that we need to do to avoid problems down the line and to give people better access into the future. And you answered the question very well yourself, which is that it's very difficult, isn't it, to get that sort of all those priorities matched together, because we do have to deal with the here and now, and we're under massive here and now pressure. But all I can do is give you assurance that we are absolutely not putting all of our eggs in that short-term basket. We are focusing in, and one of the 7 portfolios has a longer time horizon and looks at the things that we need to do, and housing and so on are absolutely part of that, of working in a longer time frame that will make a difference down the track. On some of the specific points you make around training and public awareness, actually, again, I've referred a few times now to the event a couple of weeks back, and Richard Harling led the table on emission avoidance, and that was one of the, I think it was 6 actions that came from that table. One of those was around really sort of ramping up the extent to which we communicate with people, because there are many options for patients around alternative pathways, often aren't taken up, and sometimes it's actually our own clinicians in the system who aren't aware of those options, but certainly patients often aren't, and go to A&E because that's all they know that exists. So you're absolutely right, the part of the solution here has to be that whole awareness piece, and it is very much part of our plans, although yes, you are right, we are having to focus on the things which are most front and centre here and now.
Keith, you're okay. Okay. Jill.
Thank you, Chairman. Thank you for your presentation, Paul, and very pleased to hear you talk about the many options that are not taken up by your patients. To me, we fail our residents at every point when they become ill in their own homes, and the Chairman's already touched on people with no voice. Our elderly, our frail, our vulnerable, very quickly end up in hospital with no voice. And the beginning of their journey is that they spend hours and hours and hours calling 111, 999, their own doctor, and anyone that they feel that can help them. They live on their own, they become very, very frightened, and that's what results in an ambulance. I noticed that on page 23, it says once moved to a hospital bed, they then become deconditioned. It sounds a little bit like my old car, if deconditioned means that it's absolutely failed. And I personally have a lot to do with residents who are in your hospital wards at the moment and have no voice. Providing rapid support at home, it doesn't happen. The GPs are overwhelmed. I see so many patients who are having visits from the local nurses, district nurses. They'll perhaps come once or twice, take a few bloods, then they don't see them again. Again, the patients become really frightened. If we're going to have the elderly, and once again I'll say it, those with no voice, then they will be taken to hospital. They will be put into an ambulance and sit in the corridor for up to 8 hours. They will be put into a hospital bed. They will be drugged up so that they have no voice. They don't know where they are. They don't know who they are. It's obvious, isn't it, by the passion that I'm speaking with, how strongly I feel about this. But I definitely believe that our GPs initially are failing them, and then they're moved to the hospital and their voice disappears. They're there for ages because social care hasn't got the facility to place them anywhere or look after them. Thank you, Paul. Thank you, Chairman.
Paul, we're with you.
Jill, I completely share your emotion on this. I'm completely with you. It is distressing that on occasion we're letting people down. We're, as you say, we're admitting patients to hospital. They don't have the voice. The hospitals are so busy. They're there to primarily they're trying to stabilise patients and discharge them. That's their focus, and that's not necessarily always in the right interest of the person. Completely share that frustration with you. Again, I am no filled with hope actually, because the session that we had where we did all come together, and I've been working in this system now for about 3 years, and I can honestly say that we're making massive step forwards in terms of the way we work together, the kind of communication that we're having, and the shared desire to change what you've described. It's absolutely there. It's extremely difficult. It's extremely difficult to do all that when it's not as you say, with GPs are not able to give the care they want. It's not that they don't want to. It's just they haven't got the time. There aren't enough of them. All that stuff makes it really, really difficult. But what I detect is that we're not in a kind of a doom loop of despondency. We're in a place where we're saying, well, actually, there are things that we can do better together. I'll just use one example. There's so many I could use from what you've said, Jill. One example again, which gives me great hope, is the virtual ward concept, because that allows people to be safely cared for in their own home, which is where they want to be. It's in its infancy. We haven't really got anywhere close to maximising its potential, but it's one of the many examples. Then we've got the CRIS service, which has been so successfully rolled out. So we've got things which work. We've got people in the system with a real commitment to address the things that you've said. Is it easy? It sure isn't easy. Have we got enough money? No, we haven't. But can we do an awful lot better with what we've got? Yes, we can. Yes, we can. And that's the commitment I heard from the room. And just working together across health and social care, we can make a difference, and we will.
Jill, we're with you. Do you want to come back? Just a question for committee, really. Paul has mentioned virtual wards. That is something which is one of those innovations that is coming down the line. Some systems are adopting them faster than others. And equally, we may want to think about walking the patient's journey just to see what that looks and feels like, and actually whether there isn't some opportunities for for a better integration between all partners. And there may be a piece of discussion we might want to pick up with Health Watch on that. So maybe this is something we might want to come back to. I'll leave that. I know a couple of members have just indicated on this whole subject area. So maybe we'll come back to that. Welcome, Paula. We're with you, and you're the last question on this topic, because I would like just to move on after this.
Well, thank you for that. Following on probably from the last question, really, has the cost of energy, which is expected to only fall slightly this winter, have you been able to factor that into your strategic thinking at all? Thinking especially of elderly people maybe being asked to stay at home, etc. Last winter we saw all the headlines about heat or eat and the concomitant increase in poor health, respiratory diseases, etc. I also noticed from the figures of last year that there was an increase in flu and respiratory illnesses from November, and it was anticipated it would be January. Like I say, with the cost of energy not sort of going down too much, it's still going to be expensive for people. Have you been able to factor that in?
Thank you, and I like the way you linked several reports in together there, so well done, thank you. Paul, we're with you.
Well, Paul, in terms of the cost of energy to the health service, yes, we've built that into our plans and made an estimate of what impact that would have, and try to accommodate that. In terms of the impact on individuals of the fact that they are encountering difficulty in paying their bills and therefore don't have the heating on and therefore fall ill, less so, because Phil's got his hand up, and he's probably better placed to answer the question around the uptake of healthcare for that cohort of the population.
Paul, or anything else you want to come back on?
No, thank you. It does seem to be an unsatisfactory situation nationally, actually, but it's something that I think we ought to be mindful of and possibly anticipate for the winter months.
Yeah, and I think anyone within public services has a role to play. It just depends on what role that is across the system. Phil, let me bring you in.
Yeah, thank you. Just to pick up briefly around the flu point. So you're absolutely right, and I'll come on to that in the surge update in a little while, but we are tracking very closely what's going on in the Southern Hemisphere, which is always the early warning indicator, if you like, for what we are likely to experience now. As we know, last year flu came, as you say, very early, and the gradient was very steep. We've seen a similar start to the flu season this year, although in the Southern Hemisphere, although it's levelled out much sooner. So certainly when we're planning our capacity and things for winter, which take account of the demographic changes, socioeconomic factors, and the likely prevalence of flu, COVID, etc. We are trying to use as much intelligence as we can to play into that planning, and indeed learning from last year to make sure that we've got services prepared and lined up ready. The other one I should just mention is the Strep A, which again became a very serious issue last winter during December. So we're taking all the learning from those to play into our planning for next time round. Thank you.
Absolute last words goes to Kath.
Thank you very much, Chairman, and thank you for the presentation. It's not a question, actually, Chairman, it's more of a comment, if you don't mind. There's a lot of work gone into this document and a lot of words gone into this document. My hope, and I'm sure the hope of the members are here, is that it's the residents will reap some of the benefits of what's in this document. I've sat on many health scrutinies over the years, and I've seen documents like this in the past. And actually, sorry, I've got to be a little bit negative. I want to be positive, but I have got to be a little bit negative. I've seen documents like this before, and they just get printed and it all looks good, but we need to see the outcomes of these. So I'm hoping that we will keep our eye on what's being presented in this document, so that we can come back at some point and say, great, it is what it says, and that it's not just another document that sits on a shelf. Thank you, Chairman.
So thank you, Kath. That's really helpful, particularly as there's some strands in activity here that I know that Councillor Edger wanted to ask questions on in terms of maternity and neonatal, and that's something that we've picked up separately as part of Ockenden, but it is part of the work programme. And so one of the questions for committee is how do we pull this back together again so that we're satisfied that we've done sufficient, robust work here. But let me just pull this item to a close. I was going to ask Paul a question which will sort of fall in between these two pieces, between the operating plan and the KPIs, which is the next piece, and I'm aware that you're on a tight timescale. But there's clearly an interlink between the operating plan and the KPIs, and we need to be able to see that there is a measurable benefit that goes through in terms of the delivery of the operating plan, and we see it come through in terms of the KPIs themselves. And so there's a good sort of linkage in the agenda there. Just picking up the comments around committee, I think there's a strand of activity we would benefit from doing work on in terms of the pharmacy. I think there's potentially some discussion in terms of that frail elderly, discussion in terms of the pathway and how that looks. Equally, I think Charlotte Atkins' point about missing of timescales and phasing over the 3 years of the plan, I think would be useful to understand and see more of, because, what am I going to see different next year as a resident? What am I going to see different in year 2 and in year 3? And I think that's sort of, it's woven in there, but it's difficult to track and see and to be able to go forward from. And then obviously, there was other things that fit within our agenda, but I think you ask us to note the plan. Let's do that if committee are in agreement, and let's come back to some of the strands just to make sure we drill down to the next level down on those key strands for us, because actually I don't know, there's 40 odd pages, Paul, within that document, and I struggle to understand which of the two you must deliver, which of the two priorities you must deliver, and the others are really important still, but which are the real important ones? Bernard would normally tell me it's diabetes, and Nan would tell me normally it's mental health. So I guess the real question there is, it's not as clear as it could be in terms of what those two priorities that everyone focuses in on, come what may. It's the only conversation that people have first, and everything else is a follow-up. But let's just leave that where it sits. Paul, thank you for your time and insight. It's been really helpful. I think it is, as Kath Perry indicated, a very complete document. We just now need to make sure that it delivers for the residents on the ground in the way it's anticipated and hoped for. Are we in agreement with that and to note the report? Thank you. Paul, rapidly we'll move on to KPIs. Stay with us as long as you can. And do you want to just say a word or two just in terms of opening that up?
Yeah, well, thank you, Chair. And actually, those comments you made at the end of that last item were very, very helpful, actually, because I guess, we are here trying to monitor the key KPIs that we've identified as part of the operating plan. But I think from your sum up, you're right. We need to make sure we do have that sort of track of some of the longer term things as well as the short term things, and we do end up often just looking at the short term things and then they're missing the longer term things. So yes, I think that was a helpful feedback. So thank you for that. I will certainly reflect on that. The report before you is mainly how we're looking to report in the new way, and hopefully you'll see there that you have tried to again adopt the principle that you've described of focusing down, and in doing that, the conversation here this morning has proven that there are so many different parts to health and social care that it's very, very difficult when you do that, because you suggest that other things are not important, and they're all important, but we do need to make sure that we address the priorities that we've set. So the triangle that I referred to in the first item is shown again on page 77 of your pack, and the top of that triangle, which is the waiting times with the number of people coming through category 2 and category 3 for ambulance waits, we have reported on, and pleased to say that on those there is some evidence of impact. In both cases, numbers are starting to reduce. Of course, it's early days, and we've got a winter ahead to get through. So I don't think, we're certainly not sitting here saying we've cracked this one, but the early signs are good, and we've had a better spring probably than than we might have had, and Phil will talk about that in a second. The report then summarises the key performance against the top part, the 4 priorities that we set, and that's summarised on 1 page for you, which I appreciate is always quite long packed, but on page 81, 1 page which is certainly worth a read, which summarises where we are on urgent care, the backlog, general practice, and then the focus on complex individuals. That's probably the main things I wanted to just bring out. At the start of the pack, we've just produced some data on the end of last year, just for completeness, which again Phil can talk through if helpful. So it's early days. Wanted some feedback on whether this type of report is a lot shorter, deliberately so that it's a bit more digestible. Whether that's what would be helpful to this group, or whether the opposite is true, which is that therefore things that people are particularly interested in aren't covered, and that's the difficulty, isn't it? If we focus in on some things, we're not going to be complete. So any feedback, Chair, on that would be helpful.
Thank you, Paul. Let's go immediately to Keith Flunder, please.
Sorry about this, but really just links back to my initial conversation on terms of the long-term objectives and things that are different to everything else. So really what I'm saying is that I think priorities should change. Hopefully the concentration on reducing waiting times and all things like that within the hospital system would then hopefully mean that your priorities could swing back round to trying to, in prevention side of stuff, which is what I've bring up already. But it's that development of those KPIs and things that I just don't see in the report. You do react to trends, and obviously that's something that we are aware of in terms of there's a flu document later on which shows flu rates going back up and all the rest of it. So I just would like just that recognition that over time KPIs and things like that should be looking at changing along with your priorities and the long-term strategic plan to try and make us all healthier and well, not necessarily wealthier, but wealthier in terms of longer lives and things like that. So I do think the two are linked, and until we can relate one set against another, we won't be seeing the light at the end of the tunnel. I just think that rather it's a bit negative all the time, and I understand the reasons for that, and I'm not saying that those priorities shouldn't be there at the moment and laser focused on reducing those figures and things, but I just think that might be some piece of work that you could then do with your partners and everything else to try and develop objectives and targets that would relate back to what they're doing as well as what you're doing immediately within the NHS itself. I hope that makes sense. Thanks.
Paul, is there anything you want to pick up from that?
Yes, thank you, Keith. Yes, just very, very briefly. Yes, absolutely. That sort of rotation of KPIs is absolutely the idea, that we would measure something for a while, we would get a grip of it, and then we'd move on to something else. So that I can assure you on that point. I think, as I said, probably reflected on the chairman summing up, probably what would be helpful in this report is to have some of those sort of longer term KPIs alongside the short-term ones in the same report. So I'll take that away and see if we can do that. I mean, we do have KPIs that we've got. The trouble is we've got thousands of them. That's the thing, and it's clearly you don't want to report with thousands of pages. So it's about selecting the ones that we are focusing in on at any one moment, which I think is behind your question, Keith, and you're quite right. But perhaps we've just been a bit too short-term in this, and we just need to evidence that we are also tracking some of the longer term KPIs at the same time. So Chair, with your permission, I'll take that away and see if we can address that point.
Thanks. And I think Keith touched on sort of some of the social care. Well, he touched actually on the preventative side of things, but obviously the same would be true for social care. I know that we are still working as a committee, I'm waiting for a nod, Zach, on social care KPIs, are we? Ongoing. Okay, so it's ongoing, and so we're working on it. Is that something we're working with Paul and his team as part of the integrated care system on, or are we working with it with Richard Harling?
Richard.
Okay, and will he provide the preventative side of things as well?
I'm not sure.
Okay, so I think the answer is we'll pick up the answer for Paul and for Keith, I think, is we still have work to do to create it to being an integrated pack for Staffordshire residents on health and care, and it needs to include social care within the report, not necessarily in the same table of figures, but in the same report, and it needs to embrace preventative health as health prevention as well as social care. So that is noted and is still something on our outstanding list.
Yeah, I'm just thinking if we could also bring in the districts and things like that as well in terms of the structure that we've got at the moment, and also work that's ongoing with the hubs and things that make sense to people locally, so that we can then hopefully that will then open up the corridor as well to be able to promote and to be able to be more successful in changing people's lives in the long term. That was all. Thank you.
Yeah, I think we share the same ambition, absolutely. Bernard.
Thank you, Chair. On page 4, the key metrics and deliverables, the second column there, just a question, an observation and a question on the terminology that's being used. Long-term condition programs, and then it says diabetes, epilepsy and asthma. Now, diabetes, that if you were in another NHS meeting, we were saying that type 2 diabetes is something that's manageable and perhaps curable. So I think to use the generic diabetes there isn't a good thing, because we know that type 2 is significantly different from type 1. So I would ask that you could perhaps separate them and put a bit of clarity around what is meant by long-term conditions when you mention diabetes. Thank you.
Paul, with you.
Yep, absolutely, Bernard. Yep, we do measure both, and you're quite right. There are different treatment plans for the different types of diabetes. So yes, absolutely, we have that. Again, that's a more granular level, but that exists within the data set and the KPIs.
Janice.
Thank you. Clearly, there's an awful lot of data that's gone into being able to prepare this particular piece of information. But there was two parts that make me think to just have some understanding of the reliability of the data. The Chair mentioned in the previous item about virtual wards capacity. In this particular part, it's mentioned, and that there's an issue with regards to the data that's being reported, and consequently then we've got a lack of visibility. But obviously there's great ambitions for what the virtual ward would enable recovery predominantly. And then there's also another element when we look at GP appointments, and it also makes a comment there about the data that's going through. Can you just give us some comments on that and also the confidence factor that we have in that place?
Over to you, Paul.
Yes, thank you, Jonas. Yeah, I think increasingly confident on the reliability of data. I would say, creating the shared data is the way we're doing that, so that we all draw from the same pool, and that's not yet complete. But the shared care record is an example where we're starting to do that and collect that data in one place, and all use it from the same source. All sorts of complexities, which we won't go into now, around information governance around that, but that is the direction that we're on. Having one data system that we all draw upon, and a good example, Phil Gunn's coming in next, but the creation of we call it Shrewd, but a system that has one data set for urgent care and the number of ambulances waiting, the number of patients in the A&E departments. This is an example where we've actually now got single data sources and we're all drawing from it. We aren't there yet in all regards, and you mentioned virtual wards. That's a developing area where we haven't yet got to that place, but that is the clear sense of direction, is that single data source that we all draw upon, so we don't argue about whether the numbers are right. Instead we start talking about what to do about the numbers. I'm increasingly confident that we have got that grip on data actually, but yeah, there's always room for improvement, and as new services such as virtual wards come into place, there's always that sort of at the start the issue of how do we count things and how do we count them collectively. So yes, I take the point, but I do feel generally that this is an area where we're where we're getting increasingly strong.
Janice.
Thanks, yeah. I think by virtue of the fact that it is a virtual ward, there's an awful lot of data that's being used there. So in terms of the ambition then to be able to decide what data is going to be meaningful to report back, I'm assuming from what you've just said, we're not there yet, that the plan is being discussed now and that there is some time frame.
Can I bring in Phil?
Yeah, thank you. So if I pick up the virtual ward point specifically, and then I'll just touch a little bit wider on the operational data that we use, if that's okay. So in terms of virtual wards, at the moment we are monitoring the overall capacity and then the utilisation of that capacity. As mentioned already, we're not quite where we want to be in terms of having that capacity set out. Virtual wards is a challenging one from a data definition point of view, because some systems up and down the country where they'll look like they've got massive numbers of virtual wards. Well, it depends what you're counting in a virtual ward. To me, a virtual ward is somebody who would otherwise be in an acute hospital bed were they not being supported by the virtual ward. So some areas will broaden the definition and count, I don't know, if they've had a visit due to a long-term condition, a visit due to a fall or something like that, that isn't necessarily directly would have contributed to an acute hospital stay. So it's about having the classification right, and then it's about ensuring that our trajectory of capacity grows and also the utilisation of that capacity grows. And then the second point I was going to make was just around the Shrewd system. So Paul alluded to it there, absolutely right. So on our twice daily whole system calls, we have one single data source which everybody has access to, which draws in live data from the ambulance service, from 111, from our hospitals, from our community services, from mental health, from transport services, and a range of others. But we're working to build in the virtual wards data and also some more primary care data into that to give us that truly holistic picture. But what having that system does is mean that whereas our system calls at one time just over 12 months ago, we're always a little bit like reading the Eurovision scores out. Everybody was there reading off their numbers and things. We've now got that information to hand that everybody can access all of the time, so people can see where the pressure points in the system are, and it allows for much more directed conversations rather than just gathering of information. Thank you.
Janice, do you want to come back in?
The only point that I would make is that clarity on the time frame to it, so that we can be clear about when we can see that data specifically. Thank you.
Thanks. Sorry, Chris, welcome to you, and we're with you.
Thank you, Chair. Interesting couple of reports about the plan and about the KPIs. And when I sit and I hear reports like this, I ask myself a number of questions about how I gain assurance on them. So I look at the enabling factors which give me that assurance, and do I have clarity about their robustness and completeness? And the ones that I've been turning over in my mind as I've been listening to this are about the arrangements for patient and public engagement, and how the views of people and groups who are frequently ignored are actually heard. I look at the arrangements for recruitment and retention of workforce and how robust they are now and in the future. I look at the estates. Are the buildings fit for purpose? Do they need renovation? Are they upgraded? And I look at technology. And I say, is that being used to its maximum effect? And of course I look at finance, and do we have the financial arrangements in place? Because if we don't assure ourselves on all of those enabling factors, how will we know that this plan, these KPIs, can make a real difference to people on the ground? And how will we know when it's actually happening? And I suppose those are the questions that I'm seeking assurance on here today, Chair. Thank you very much. And it's good to see you, Baz. Baz and I have only seen each other on regional meetings, so it's good to see him face to face.
So, Paul, I think that's probably a broad question for you, and probably it's also a challenge in terms of, we've seen the start of the KPIs. Certainly it is not my view that this is the end of the KPIs, because I think certainly a KPI in terms of finance is really important to have within this pack. Understand these are principally operational KPIs, but I think it's a point Chris makes well in terms of where else and when else will we see these. Yeah, let's have that answer, and then I've got a follow-up if that's okay.
Yeah, no, again, really helpful points, Chris. Yeah, and I think, yeah, you are right, I think, which is that those enabling functions should give us that assurance that we need. I mean, I'll let Tracy talk about patient and public engagement, which, as you say, is absolutely one of those. I see you've got workforce later on the agenda. So, yes, I do think we've got those enabling functions much more tightly defined now in terms of how it fits together to the delivery of the operational KPIs. Again, it's a point of reflection, Chair, that in what we report here, it would be useful to show those enabling KPIs as well as the actual kind of output KPIs, wouldn't it? I think that's say a helpful observation by Chris. That is, I think he's right. That's a way that you can get that assurance that you need.
Tracy, we're with you.
Thank you, Chair. I mean, addressing the people and communities, absolutely. We've changed the way we sort of work now during the ICB, learned a lot through our COVID years in vaccines, and how we actually work with the community and with faith groups and leaders within the community that we learned through during COVID, that we're doing more of like this. In terms of actual key performance indicators from that, there's quite a number that we have with patient experience. But when it comes to public involvement in terms of changing things, how things are delivered, then we have some formal mechanisms in which, we do actually use an insight model. So we do have statistical information when we've done our formal involvement processes, or indeed sometimes just engagement process. So we do have that insight. It's just there's a lot of data around to try and triangulate, but that's something that we probably need to do.
Thank you. It sounded very much like a work in progress, but recognition of the need to pick up those elements. Chris, do you want to come back?
No, I'm quite happy with the answers that have been given, Chair. I do think Health Watch could have a role to play in developing some of those responses.
Thank you. And the follow-up I was going to sort of follow with was where do we find those indicators which are early warning indicators? Because obviously, a number of these indicators are very much of the moment, which is fine. They do show a trend, many of them, which again is useful. But where are the early warning indicators so that we can focus in on some of those to be able to say, should we be worried or not? It's a bit like, there was always a COVID number I had in my mind that always sent alarm bells ringing that we would then have a further conversation on. Where are those KPIs and which ones would you recommend that we focused in on?
I think the answer is in the trend, Chair, as you say. I think it's too complex. Personally, I think it's too complex to say there's one indicator, once it reaches this particular number that triggers it. I don't think that would work. I think it's got to be more nuanced than that. But what we need to do is make sure we've got that right sort of basket of KPIs across the piece that enables us to have that rounded conversation. So for example, we'll see if the financial indicators go the wrong way. We'll see if workforce is going the wrong way. We'll see if the increasing numbers of over 75-year-olds are being admitted, etc. But it's in that sort of combination where you get that warning, I think.
Thank you. That's really useful. Without any further indications, sorry, Anne.
Thank you, Chairman. I just wanted to, yesterday afternoon I had to visit a patient at UHNM. She's a 75-year-old. She's in there. She wants to come home. And the only reason she can't come home is because there's nobody to look after her. And it's it's just one of those situations where she's got no immediate daughters or sons or anything that can take care of her. So she's laid in bed there, wanting to come home, and I just wanted to highlight that with you. So that's one of the situations that you've got, really, which is a problem. Thank you.
And a past master at weaving stuff in on any agenda item. I do admire it. Okay, maybe Tracy and I can have a conversation, Anne, on that separately, if that makes sense. Just talking about Tracy, Tracy, can I just put you on the spot? I know that there is page 75 of this report talks about West Midlands Ambulance Service incidents. You know, could you just give us, because it will be a concern for many in this room, we've had 2 conversations on West Midlands this morning already. Could you just give us sort of some indication of the latest trend data in terms of ambulance service performance, if you have those in front of you? If you don't, we can take that as a separate written response separately.
Probably a better written response, but Phil Smith is on the call and is doing the system pressures after here, so may well tackle some of that, though Phil's just jumped on the screen now, helpfully.
Hello, yeah, if it's okay, I've got a little bit of data on that I'll pick up through the next item, if that's all right.
And sorry, do you want to do that as part of the next session?
Yes, please.
Okay, that's perfect. Let's do that then. Okay, and on that basis, let's bring to a close the item in terms of system performance. Actually, it probably should be titled KPIs because it really is trying to pick up that point, isn't it? I welcome this report. We've been asking for a long period of time to see integrated system performance. It's good to see the integrated care systems KPI pack, and I know that you measure everything to within an inch of its life, and so it's nice to have a small number of KPIs, but also some key ones. You know, I think it's still work in progress from my point of view, because we're missing those wider system discussions that we had a minute ago in terms of social care as well as preventative, but also some of the other areas in terms of workforce, technology, finance and co. And I'm sure we will see that next time it comes back. Is there an ambition to bring this back to us once a quarter? Is that the ambition?
We're in your hands, Chair, but we report these things monthly, so very happy if that's helpful to the committee.
I think it would be useful certainly to see it in a quarter's time, and then we'll make a decision from there whether we want to focus in on some area or other, but equally it ensures that we're focused on the right things that our residents are concerned about as well. Okay, on that basis, I think we've been asked to note this report. We should thank you for that. So thank you for the report. I'm sure you'll take on board the comments we've made. And let's move on to item number 6 of the agenda, which is system pressures. Paul, if you're leaving us, thank you for your input this morning. Please feel free to stay or leave as the case may be, and we will catch up soon. He's gone. Okay, Phil, we're in your capable hands now in terms of system pressures. Maybe you could have 5 minutes just to talk us through the paper, and equally bearing in mind this has been through committee a variety of times. I think it was last here in
October, I believe, we last did it.
Yeah, October last year, and I think it was then sort of 6 months before that as well. So most members are familiar, but not all, because we've had some change in committee. And maybe you could pick up the question in terms of West Midlands Ambulance Service at the end of your introduction, please. Thank you.
Yes, thank you. Okay, yeah, so as just mentioned, last here on the 3rd of October, at which time I was able to outline what our system plan was for heading into winter. So I'll just very briefly, as the paper does, just touch on the pressures that we did experience over winter, very crucially our learning as a system and the way forwards, both in terms of our planning for surge and also our general improvement plans and areas of focus, some of which have been picked up earlier in this committee. So just to recap very briefly, our system winter plan was built around the principles of capacity, workforce and escalation. So ensuring we had the right capacity in the right place, serviced by the right workforce, and that we had appropriate mechanisms for escalation and response to manage and share risk across the system. So the system winter plan went through indeed every partner for agreement and was finally ratified by the ICB board in November last year. The feeling was that it was a very robust plan. However, we did experience some severe challenges over winter, particularly for one period in December, from the middle of December essentially to the middle of January, which gave us some quite significant challenges to manage. So I'll just pick up those bits which largely fall into the critical incident that we declared from the 29th of December up till the 12th of January, just to pick up the kind of variation there that gave us challenges. So number one was around demand. So during that particular period, we had flu, which I mentioned earlier, which rose by I think 136% in a very short 2-week window. We'd also had an almost 70% increase in COVID admissions. We also had RSV, and we had the impacts on the wider care services around strep A that I again previously mentioned, which gave us significant challenge. This was all at the same time impacting on our workforce as well. So sickness levels of our core capacity ranged up to 10.3% in December, and we were also very much challenged around vacancy rates. We originally set a winter plan that recruited around 350 additional people, and I think we, at the end of winter, we probably got to about 60 to 70% of that, but clearly workforce gaps were a challenge. And then the other part really was supply in terms of physical space, having the right space to cope with the demand that we were seeing. So, for example, that very difficult time in December, we had a surge of very acutely unwell people who needed an acute bed. Therefore, although we may have had space in community, it wasn't sufficient to be able to meet those patients' needs. So it was about matching the capacity to the demand that we had. As the paper sets out, we carried out a system winter learning event in March, and I won't go through all of the details of that. Suffice it to say, we looked at it from a number of perspectives. One, which was around the process we went to develop the plan for winter. Secondly, around workforce and recruitment. Thirdly, around that risk sharing and clinical decision making. Fourthly, in terms of how we responded to the system critical incident and how we could have planned for that better. Fifthly, which I think is a really important one, to what extent we adhered to our system leadership compact. So that's very much a behavioural compact in terms of how all the agencies linked together during that period, and then also looking at the money we spent, the money we were allocated, and then finally going into looking at the opportunities for the year ahead. So quite a wide-ranging session, and again, happy to pick up any of the specific points around that. For me, the three key things were around making sure we've got an early start in terms of planning for winter, particularly in terms of workforce. There is no point starting to try to recruit people in October and hoping to have an impact in November. That's a process that needs to start much, much sooner. We also recognise the need to tighten up our early warning and our risk share processes in order that we can manage periods of escalation better, and the need to make sure we fully understand our demand and capacity. In terms of looking ahead to this year, the two things I'll just mention are firstly around our urgent and emergency care improvement plan, which has been agreed through our UEC board. Again, all partners are members of that. It focuses around a few key areas. One is around access, and again, picking up themes from discussions earlier in this committee, making sure that we have community-based access to enable people to be supported in their own homes for as long as possible, and to provide alternative pathways to avoid hospital attendance. This is very much driven by the fact we know we are an outlier in terms of the proportion and the number of over 75s who both present at hospital and are admitted to hospital. And as we've touched on earlier, that can lead to deconditioning and unnecessary over-medicalisation and poorer outcomes for patients. So very much making sure we've got the right things in place to avoid unnecessary escalation to hospital. The second part of the programme is looking around the internal flow within our hospitals, looking at how decisions are made, how flow is handled through hospital to the point of discharge. The third bit is around discharge itself, making sure people get to their usual place of residence as quickly as possible and are supported to stay in their usual place of residence. We've had some real success through our discharge to assess pathways, but we have seen an increased proportion of people who are going home with support and needing longer term support. So that's very much something we need to focus on. And then it's very much about understanding our, again, demand and capacity. I'll just touch very briefly on the system pressures that we've seen so far this year. I think it's fair to say our capacity model, aside from that window that I talked about between December and January, was accurate for the last 6 months of last year. But we have seen some deviation in the early part of this year, and certainly in the last month or so, we've seen increase in ED attendances and increase in demand, largely linked to trauma, but also some medical increases as well. And despite that, I think it's important to say that we've held and indeed improved ED performance. We've also seen our Cat 2 response times for ambulances hold around the 30-minute mark, which is where we're aiming to be for this year. So very much kind of holding our own in the face of the pressures that we've seen in the last month, but it just underscores the need to deliver the long-term improvements that we need from our UEC improvement plan, which for me, as we look ahead to planning for surge for this next winter and indeed a whole year of surge, because as I've learned in recent weeks, a day in July can be as busy as a day in January, and indeed busier in some cases, as I've seen in the last week or so. We've got to be addressing the underlying causes here, not just trying to address the symptoms. The symptoms of the problem are where we have ambulances building, where we have delays in ED, and where we have a need for more acute beds. If we do nothing in our current position, we'll essentially have to build an extra ward of acute beds every single year as we head into the future. So clearly addressing those underlying issues around how we're managing long-term conditions, how we're managing end of life appropriately, how we're managing frailty appropriately within the community, and then conversely how we are managing reablement and promoting independence following any period of escalation are absolutely paramount here. The solution to our problems cannot just be in exponentially building more hospital beds every year. So surge planning is very much underway. As I said earlier, that's been informed by our intelligence around what's going on with flu. We're also looking at some predictive data around COVID and other demand factors linked to the demographics as we look ahead for winter. Solutions for winter will not only be acute based as ever, they will also involve all partners, and indeed all partners are involved in the design of that. So primary care, our voluntary sector, community services, social care, mental health services, and other agencies such as hospices all have a really vital role to play in terms of planning for surge as we head into winter. I'll pause there. Hopefully that's given a reasonable overview of the paper that's there, and happy to take questions. Thank you.
Thank you, Phil. Let me bring in Charlotte Atkins.
Thank you. For your comments and the very fact that you're starting surge planning in April for winter indicates to me that the NHS is in crisis the whole year, and it just gets a little bit worse in winter. So I think that that's the reality of the situation. But what I wanted to do is ask you to explain a couple of your points on page 83. First of all, what does the wider expansion of the system workforce hub to ensure social care coverage mean? And secondly, in the point G, which is greater involvement and input from voluntary care and other sectors in future planning. That's the second thing I'd like you to clarify. And thirdly, could you say a bit about urgent treatment centres and how they fit into the plan?
Yes, thank you for the questions. I'll pick up a few of those, but I will ask Mish or Gemma to just come in around the workforce hub one when I've done that, if that's okay. So firstly, in terms of planning for surge, you're absolutely right. It is a whole year thing, and the models that we're developing now are 12 monthly views in terms of what to expect. So surge happens at varying points of the year. It's just that we tend to focus around winter because that's the most significant. So absolutely valid point there. The point around the input of the voluntary sector is absolutely crucial to me, both in terms of supporting people to remain in their home and then also supporting them in terms of discharge. So there are a number of agencies out there who will support us in terms of getting patients. It's what we call a simple plus discharge. So a simple discharge is a patient being discharged with no support. However, a simple plus discharge means that essentially the patient just has some settling in support at home. So it might be sorting their shopping, getting a clean done for their home, or just something just to help them in those first few days to settle in. And we've seen some real success with the voluntary sector agencies in terms of supporting with that. And that's something we really want to promote going forward, so that people aren't put on a formal clinical support pathway if it's not needed, if it's purely about essentially a settling in service. So that's one key area, but there are other opportunities there. Urgent treatment centres, absolutely. We're in the process of working through designation of urgent treatment centres in our system, and that's something that we've got to make a recommendation on by the end of the financial year. So that will clearly play a role going forwards. And again, that's very much about ensuring that the acute hospital is seeing only acutely ill patients, and that we're able to offer services including diagnostics in local settings to avoid unnecessary attendance at acute sites. I'll pause there and just hand over to Mish to just pick up around the expansion of the workforce hub to include social care. Thank you.
Before you do that, can I just come back on the voluntary sector? When you say that, are you commissioning voluntary organisations to provide that, or are you looking for volunteers within the community to deliver that service? And in terms of the urgent treatment centres, where are they?
So, so in terms of the voluntary sector, we're working with a number of agencies to provide that support. So we are linking with organisations to be able to go in, be that Age UK, Revival and others locally, to provide that support to, again, prevent escalation and also to support people coming out of hospital. Urgent treatment centres, that there's been a system technical event which was held last month, I believe, to work through the options appraisal based on data for that. As I say, we've got to, by the end of the financial year, a decision will need to be made through the ICB board around the designation of urgent treatment centres, but that's currently just working through in terms of the process of that data, the process of discussion with partners in order to formulate the recommendations there. So we'll be able to give an update on that in due course.
Mish, we're with you.
Thank you, and thank you for the question. Yes, the workforce staff mobilisation process is something that we pulled together throughout COVID. So it has been a really system collaborative response in which we've tried to understand where the workforce challenges have been and help to encourage our colleagues to move to the areas of highest need. What became clear really early on was that we did have significant gaps within home care, social care, care homes, etc. Now, this workforce, as I'm sure you're very well aware, is a scarce resource. It hasn't necessarily been one that we've been able to retain our workforce in successfully as well. So what we decided to do was to try and create something new, create a model where we weren't going to be poaching workforce from our colleagues in social care, but actually supporting our population to come in to work with us. So what we did, we've created our People Hub, and on that we have a number of individuals that we've trained from scratch to work either in home care or care homes. We have them as reserves as well. So some individuals are full-time, some individuals are reserves that work part-time and kind of will stand up when we ask them to. So that's, I guess, and Phil, let me know if you want me to expand a bit further, but that's what it refers to in terms of expanding our workforce mobilisation approach into social care.
Thank you.
That's great. Thanks, Mish.
Anything else you want to come back on, Charlotte? Okay. Can I just pick up just as a supplementary to where Charlotte was, I think. It strikes me, if you look at those people who are most vulnerable, most likely to end up in A&E and then need to be admitted with flu or respiratory viruses. And then you started saying, okay, so how do we de-escalate some of those people? How do we better support some of those people in the community? It would strike me that some of those people are in care and residential homes by the nature of who they are and their age. And actually, maybe some greater intervention into those locations may de-escalate people more quickly. It links to, I think, in part what Jill Hood was talking about earlier in terms of frail elderly. And I'm certainly not saying everyone who is elderly is frail, and that is not what I'm saying, clearly. But what I am saying is where are the other predictors, and what could you be doing in the community to reduce admission because you've intervened earlier?
Yeah, I think the point around care homes is absolutely really, really important, because our intervention with an in-reach, as we call it, into care homes needs better coordination. And that's certainly something, again, within our plans that we're looking to do, because we do see quite a high proportion, understandably in many ways, but high proportion of ED admissions coming via care homes. And also we see significant volumes of end-of-life patients coming from care homes, which again is not necessarily appropriate for the patient. So having that in-reach and wraparound support into care homes, be it as simple as GP rounds into care homes, if you like, as well as other supportive services such as the fire and rescue service. We've provided an absolutely excellent service to us over the last winter, and something that we're going forward with and building on around falls response, where they're supporting people who've fallen to help them physically get back up again, and carrying out some basic checks and providing that service into the community and into care homes as well, in a way that prevents a need for escalation and hospital care, if you like, has seen a significant impact for us. So those schemes are very, very important. Care homes are very, very important. And it's, again, monitoring the trends of admissions for particular care settings and within that particular providers themselves, to see if we have any high referrers, if you like, and see what more support we can put in. But working with that care home market is absolutely crucial for us. Yes, thank you.
Thank you. Before I bring in Kath Perry, just coming back on that, I mean, I think, looking at GP wraparound support back in the day, the GP would have gone around care homes on a very regular basis. Given you guys are the commissioners of services, it could be done something that is outside of the GP contract, but it would have a huge financial benefit, because at least you're not admitting people, and it would probably have a huge benefit to the individuals who are frail by their very nature, and not getting flu or RSV of some sort would be clearly beneficial. Let me leave that point there. I think it's landed. Kath Perry.
Thank you, Chairman. Paragraph 9 on page 82, the winter plan. I understand you had a seminar to discuss this, and I'm looking at the people that attended. I just wonder, my question is, are all of the trusts around Staffordshire involved in this as well? Because I'm thinking of cross-border issues that patients are taken to. They could well come into that paragraph, I don't know, because you mentioned them there. But I'm just asking the question, are they all on board with this winter plan? Because a lot of our residents are patients outside of our borders, and they have the same needs to get back to here. So could you answer me that, please? Thank you.
Just before you do, for reference purposes, and Kath is exactly right, 40% of our residents consume health services outside of the county. So really important point, so thank you.
Thank you. I was about to start with 58% of our patients are serviced by the UHM, but I think that works with that statistic that that 40% are serviced out of county. Absolutely right. And in developing our winter plan, we largely engage with University Hospitals of Derby and Burton, and also Royal Wolverhampton Trust, because those are our two main other providers in terms of patient flows. But similarly, we've got flows, I think, up to 10% flow outside of that, be it, Good Hope, or indeed some flow to the north, up towards Macclesfield and places. So we absolutely involve partners from University Hospitals Derby Burton and RW Royal Wolverhampton Trust in terms of developing our plan, and we socialise it with the others. But it can get quite tricky in terms of each health system will develop its own plan, so it's about making sure we're all cited on each other's plans. But by involving University Hospitals of Derby Burton and Royal Wolverhampton, we're sort of achieving over 90% of our patient population, and then maintaining dialogue with the others. I should also say that every single day throughout winter, we have a call at 10 o'clock in the morning, which is all of the Midlands providers together. So there's an opportunity there to share updates, seek mutual aid, and also flag any issues that there may be to help us navigate our way through, because very often we'll have patients in Dudley, for example, who need to be repatriated back home into Staffordshire and need services put in place for those. So if there's any particular escalations, we'll handle those on a day-to-day basis. I hope that answers the question.
Thank you, Chairman. Thank you very much. I just think that to make the plan work, it needs all parties on board.
Janice, we're with you.
Thank you, Chair. I'm just going to ask my questions in reverse order, because we're looking at sort of how patients are accessing the system and then how they're being discharged. But picking up from the last but one question, I think if we go on the discharge one first, a resident was in touch with me, and I certainly won't go through the specifics today, about consistency of the reablement support. Now, for general purposes, this is how we can try and avoid patients being readmitted on a number of occasions once they've been discharged from hospital. I've asked those questions separately elsewhere, but I think it would also be helpful for a conversation about that at this point as well. And then with regards to going into the system, are there any working conclusions that are being extrapolated at the moment of the effectiveness of signposting, looking at some of the figures and the data that's in there, for example, on 111 and things like that? Thank you.
Thank you. So if I pick up firstly in terms of discharge, so yes, absolutely, the reablement offer should be consistent throughout the system, and we do monitor readmission levels for individuals to understand where those services may not have worked effectively. The home first model of reablement through either community-based or bed-based care is a model that's signed off by all partners, includes regular checkpoints and obviously input from clinicians in order to essentially seek to maximise and turbocharge the reablement period for people by providing that wraparound support in order that they can. The intention is to go on to regain their independence once again, or if they do need to move on to long-term services, to support mapping that transition. So it is something very much that we are cited on, and again we do carry out regular audits in terms of those readmissions and therefore the effectiveness of reablement services. Around access, absolutely. What we've seen, particularly with our community rapid intervention service, which is essentially designed to provide what's known as the 2-hour urgent community response to patients, we've seen real improvements there where either 111 or the ambulance service themselves signpost to that service. That service then has people who can go out to people's homes, support them there, and again prevent unnecessary conveyance stroke admission to hospital. We've had a number of pilots over the years. So for example, what we've now landed on in terms of an embedded model is 3 times a day our community teams will link with the ambulance service to review what's on the stack, what's on their list, if you like, to try and identify and pull patients into those services to avoid ambulances having to be dispatched where not necessarily required. And also we're ensuring that we've got the right access routes from 111 through into that service to access that urgent community response, and also directly into primary care to be able to access urgent slots within there. That for me is the area that we need to concentrate on and grow and gain the consistency, because that's where we will see the benefit in terms of people not unnecessarily, as I say, being conveyed or admitted to hospital, because there's certainly more we can do there. But we've had very recent evidence which has shown the effectiveness of working in that way. The other thing I would just say here is part of our system event that Paul talked about earlier, we were talking about single points of access, and as a system we have many single points of access, and actually what we need to do, we agreed as partners, is come together to develop a single point of access, because for care professionals, be it the ambulance service, be it 111, be it district nurses, GPs, if we have a very fragmented and cluttered community access, it makes it very difficult for people to know where to navigate to. But having a true single point of access where care professionals can go to seek signposting and support will give us great benefit, I believe, going forward. So that's something we're focusing on.
Janice, do you want to come back?
Yeah, just to, obviously, I alluded at the beginning that that consistency with regards to reablement probably wasn't my experience, but that's where I'm taking up elsewhere as well. But I think it's worthwhile just making sure that we have that profile. Thank you.
Yeah, I noted down that point as well about the consistency, and funny enough, I linked it to what Kath Perry was asking, because I think, Phil, what you said was there was a consistency across the system, and presumably that meant the Staffordshire and Stoke-on-Trent system, not necessarily out-of-area systems, and certainly my view was that with so many different bits of estate and different bits of services. You mentioned the CRIS service. From memory, that only comes out of UH&M. And so how can there be a consistency when you've got certain elements that aren't delivered uniformly across the whole of the integrated care system? Maybe you could just give us a thought on that.
Yes, certainly. So in terms of anybody who is a Staffordshire and Stoke-on-Trent resident coming out of hospital anywhere, that responsibility for providing that reablement and ongoing care sits within our footprint. So irrespective of the acute hospital, people will go through that same discharge to assess support process for reablement. So that's what I meant in terms of that consistency. I think you're right in terms of CRIS, absolutely. It largely centres around the UH&M footprint, although we do work with Burton as well. And again, I think that is a fair point around the need for greater consistency across all of the hospitals and other areas that we deal with. But certainly from a discharge to assess perspective, any of our residents being discharged from any hospital should work through that same pathway.
Thank you, Phil. You learn something every day, and that's very helpful. I'm sure we'll come back to that at some stage, either individually or as a group. Just in terms of current performance, because obviously, I think Charlotte Atkins indicated, this is clearly a year-round issue in terms of planning and mobilisation. Could you just give us some comfort in terms of the current performance, both in terms of, the overall D2A numbers, and an ambulance performance? Because whilst I'm by no means suggesting that the system issue was down to one party or another, because clearly it wasn't, but those are the front and back ends that tend to be the bits which people focus in on. Maybe you could just give us a feeling in terms of how the performance looks on those at the moment, please.
Yes, absolutely. And as you rightly say, these are very much symptoms of the whole system. They're not just about any particular organisation. So certainly in recent weeks, and indeed during most of this at Q1 of the year. We have seen improvements around A&E 4-hour performance. We're currently for UHM, for example, around the 70% mark, which is improved from where we were, but we've got to get at least to 76% by the end of the year. So that's on quite a steep improvement plan. Ambulance response times, again, we very, very closely monitor these, and the measure that we use mostly is the category 2 response time, which nationally has been set to 30 minutes for this year. And I'm pleased to say that we are seeing adherence with that in the most recent data. So ambulances are getting to people in a timely way. And then just in terms of the flow, we use this term medically fit for discharge, which may have been discussed at the committee previously. Those numbers are continuing, although we can always see improvement there. We're continuing to see good flow out of hospital. So generally, if I just pick on UH&M across county and Royal Stoke, there are around 100 to 120 medically fit patients at any one point in time. And the vast majority of those will be discharged within 72 hours. Anything that's an exception to that, beyond that 72 hours, we look at individually and are often due to complex patient need, but certainly no issues to flag at the moment in terms of flow out. What I would say, though, is something that we're looking into is we've seen an increase in the proportion of patients being discharged from hospital with discharge to assess support. So that has certainly changed since pre-pandemic. So people are leaving hospital needing more support than they were. So that's something we're looking into to understand the root causes of that, which may well be linked to all of the upstream stuff we talked about earlier in this session, as well as decision making and balancing of risk at the point of discharge, as well as the opportunity for perhaps involving the voluntary sector, as I mentioned earlier. But I certainly at this point in time don't have any specific escalations of recent data.
Really useful, thank you. And obviously, knowing some of these figures quite well, actually the majority of your medically fit for discharge in terms of that flow are those people waiting home care, which often takes more time because they're specialist packages. So useful set of figures. The only figure I would be regularly pulled up on is the ambulance service one, the 30 minutes CAT 2. Is that equally across the rural areas, given that Staffordshire is highly rural? I'm being picked up particularly from members of Staffordshire Moorlands who are concerned about whether they get the rough end of the stick with ambulance attendants.
Yeah, I mean that is a kind of a whole patch figure. So there is variation within that, and certainly the rural areas will sometimes see greater length of response time than others. I mean, I'm happy within the next update that we provide, we can break that down geographically as needed so that we can understand that, but we do monitor that variation between patches, and it can also be influenced as much in the more urban areas. So for example in Tamworth, if there's, because it's closer to Birmingham, if there's significant need over in Birmingham, the number of vehicles can be drafted over towards Birmingham, meaning that there's less available for Tamworth. So it's something we need to keep an eye on, not only in terms of rurality, but also in terms of understanding the pressures around us, and therefore where the vehicles are going. So it is something that we do monitor, and I'm happy to provide an update in future around the breakdown.
Yeah, Phil, before I bring in Charlotte, having mentioned Moorlands, I shouldn't have done that, should I? I wonder if you could just ask someone to break down the figures by those districts and boroughs, because I'm also mindful that the South Staffs is heavily rural, and its geography is not easy either, by the very nature of how it sits. So would you be able just to break those down, the next fortnight or so by district and borough, and just send them into committee, and we will circulate them around, and then we can decide as a committee whether we want to look at this if it shows up anything obvious, or whether districts and boroughs individually might want to pick that up. Let me bring in Charlotte, and then I'll bring in Kath Perry.
Yeah, you shouldn't have mentioned Staffordshire Moorlands, because it's been made clear to us in the Moorlands, particularly the rural areas, that there's no chance of an ambulance reaching the villages and the moorlands in any sort of reasonable time. But more worryingly, given that increasingly the NHS is telling us to rely on technology and on community effort and on volunteers, that we've had 2 recent deaths in the village of Ipstons, which were linked to the fact that when the West Midlands Ambulance Service was rung, they couldn't find the defibrillator on the system, nor could they find a code to open the box for the defibrillator. So despite the fact that we had family members, community members wanting to use that bit of technology, it wasn't available to them. And that meant that 2 people who possibly could have been saved died. So not only are they being abandoned by the ambulance service, but even the bit of reassurance that a defibrillator in the village might have given was out of reach for that community. And it's completely outrageous, which is why, despite the joint code of working, I'm sure that the Staffordshire Moorlands Health Committee will be asking for the West Midlands Ambulance Service to come to its committee to account for that failure. It's not as if it's happened once, it's happened twice.
Charlotte.
We don't want it to happen a 3rd time.
Yeah, thank you. I'm only aware of that case this morning, this morning, Charlotte. I think that we need to look at it in context, notwithstanding the important points you make for your residents. And we will look to do that. I think we just need to pull the data, as we've indicated from Phil. I wouldn't expect Phil really to answer this, apart from obviously extend his condolences to those people who have been involved in that sad situation. But it is important we do get to the bottom of that for not just maybe your residents, but maybe there is other areas included who need to get an understanding of that, which is why it might not be a Staffordshire Moorlands only issue, but happy to have that discussion with the relevant representatives from...
Well, particularly important as defibs are now being rolled out, quite enthusiastically. If they don't work, there's no point putting them there.
Understand that, but I funded a defibrillator in Croxton. It wasn't for me, hopefully, but I think we all have been involved in defibrillators over the years, and we all want to make sure that they work and do the job that they should do. There is 8 minutes that are important to people in that situation, notwithstanding the important points you've made. Kath Perry.
Thank you very much, Chairman. I'll welcome what you've just said about the figures, because it's not only whether you live in the rural, it also is if you live quite near to town centres, because the infrastructure of the traffic can be the result of not getting to where you need to be as an ambulance in a certain amount of time. So I think it's important that we know what these figures are, and we can have a discussion about it, and maybe district and boroughs can also do the same. Thank you.
Yeah, I think that's. I think those last two points are really important, and we should. If we're not doing the job for residents if we don't do that, so let's have that conversation more broadly. I guess it'll be. Phil, do we think we'll? When's the next meeting? It's August, is it?
We've got a meeting next Monday.
No, it won't be next week.
September the 11th.
Okay, September the 11th. We'll aim to have the data for you at the end of August. Is that okay, Phil? Can you?
Yes.
And
Absolutely.
then we'll circulate that in advance, and we can have the discussion on the September the 11th in terms of what we do in terms of that plan. And if there's more data we need, then just please flag that up. On this one, no, I want to move on. Unless is there something new that you want to add to that?
I just wanted to add that I had the reason to call an ambulance on Sunday night, actually, and to attend to a 7-month-old child. And I've got to say the ambulance arrived on time. There's nobody criticised the ambulance service more than me over the last 10, 12 years. But I've got to say on this occasion, they did a perfect job, and I was very, very happy with the results. So thank you.
Always good to feel us on balance, so thank you, Anne, for that. Phil, I would like just to bring this sort of subject to a close in terms of surge planning. I guess my only observation is sort of fits into page 83, which section 13, paragraph A, where to me it's symptomatic that, you know, maybe people are too nice within the system to call out you know, inappropriate behaviour maybe, and I appreciate the wording is probably there to make everyone feel satisfactory, but frankly, you know, if there is greater partnership working that is required through systems, system integration and system working, then maybe we do need to call out inappropriate behaviour, you know, where people are not looking at the end-to-end system and people are only looking after their own part of the system, because often people's journeys through health and care are quite complex. So maybe that would be the only comment I would leave on. Your job was to provide reassurance or assurance that this year is going to be better than last year. Have you done that?
I hope to have been able to demonstrate to the committee that certainly we've fully reviewed and we've learned from last year. Therefore, the approach and the plan that we're developing for this year will, by its very nature, be an addition to what we had last year. I think what I would suggest is that, as we did last October, I don't know how your timetables work, but we can again come and articulate the full plan before we head into winter to this committee to be able to go through that. Clearly, we've got some really fundamental challenges that we've got to address as a system, but I am confident in terms of the surge planning that we're on it early. We are gaining a greater understanding of the issues, and all partners are joined up in terms of that planning.
Thanks, Phil. That's a really helpful answer, and it probably went further than I thought you would, so it was worth me teasing you. So thank you. Do we want Phil to come back with the plan for this year in October, which is what I think he's just offered? Maybe give it half an hour, a whistle-stop tour through it, given the importance and the criticality to the whole system? Yes? Yes? Are we all in agreement, Charlotte? Yes? Yes, okay. Phil, we'll take you up on that offer. Thank you very much. We'll diarise something and come back to you. Thank you for your input to that, and thank you for the paper. And let's move us on to the elective care update.
Chair, can I just... It was only what... I didn't say anything in this debate because it was brought up earlier, but it's the involvement of the voluntary care and other sectors in future planning could be an idea to come back on that as well. In that thing.
Yes, that will very much be part of our planning, and we're linking with those partners at the moment. So I'll be able to bring that in the update. Thank you.
Brilliant. We have a plan. Okay. Phil, I believe you're leading us on the elective update as well.
Yeah, so I'm actually, if it's okay, just going to hand over to Mark Seaton, who is our Portfolio Director for Planned Care, to just talk through the highlights of the paper that we've shared, and then both Mark and I will be able to respond to any questions and support the discussion. Thanks.
Thank you, Chair. Thanks, Phil. The paper is presented as it's in your papers in three sections. And it's basically a state of the nation of where we were at the point of writing in terms of our progress on recovering the elective backlogs. Colleagues will be aware the significant impact that the COVID pandemic had and the scale of the impact. And it's resulted in many patients previously waiting beyond 2 years. So the paper reports where we are with those patients and also the latest milestones of those waiting both 78 weeks and 65 weeks. And just to put that into a context, the national guidance is that we should have treated all people waiting beyond 65 weeks by the end of March 2024. The inference there very clearly is there is no quick fix to this. And as I state in the paper, bullet point 4, it could take up to 4 to 5 years to complete the backlog clearance in full. So there is a report basically looking at the various measures and where we are. Staffordshire as a whole, in terms of long waiters, is not doing particularly well, but progress is being made. There was an expectation that 104-week waiters would have been treated by now. Unfortunately, we still have a handful that are proving difficult, and there are a number of reasons why we've got those. And some of this is down to learning. I mean, we haven't had one of these pandemics before that's impacted like this. But a lot of these patients that have waited a long time have been really reluctant to go elsewhere for treatment, even despite it being offered for them to get treatment earlier. They've chosen to continue to wait for local treatment, which is not typical of other areas where the national mutual aid arrangements has had a much greater uptake. But the good news is that those numbers are coming down. I think it reports in the paper when it was written that there were 9 104-week breaches. That's now down to 5. So progress is being made. 78-week waiters, there is a summary in the paper of out-of-area providers. And of course, there are a few sort of spread around the country of Staffordshire and Stoke-on-Trent patients that are waiting for treatment in other areas. The largest proportion, as we might expect, because they serve a large proportion of our population, are in UH&M, and those figures are mentioned in the paper, including the trajectory to reduce those numbers further. And there is now an expectation from NHS England that we should be aiming to have all those patients treated by the end of September. 65-week waiters, as we've mentioned, that the expectation is that all those patients should be treated by the end of March. As a system, we are slightly off track, in part because we're still focusing on the 78s and 104s, which we hope by now would be cleared. But there is both time and ambition to recover those areas. Cancer services, as I mentioned, they're prioritised during the pandemic and continue to be so. There are some areas of really good performance and there are some areas of challenge which are included. So in terms of the faster diagnosis standard, this is basically an expectation that people that are referred with a suspicion of cancer have a diagnosis that rules it in or rules it out within 28 days. 92.5% locally of patients with referrals for breast cancer are told within 28 days. That is a significant achievement and really good. At the other end of the scale, where we're struggling are around endoscopy capacity. So 34.8, just short of 35% of patients with referrals with lower GI cancer get a diagnosis within 28 days. Plans are in place and the demand and capacity modelling that's been undertaken, our endoscopy capacity over the next few months exceeds the demand, so that those backlogs should be cleared. And the expectation is that will happen in the next month or so. So we have got a plan to improve that. The reason why that's important is the second standard that relates to cancer, and that is that patients that are referred with a suspicion of cancer are diagnosed and commence treatment within 62 days. It follows that if we can't diagnose them quickly, we're not going to start treatment quickly. And therefore, the expectation is that faster diagnosis around endoscopy will have a significant impact on the 62-day standard as well. I did put in some comparative figures there. So whilst Staffordshire as a whole is achieving 57.8%, that is, of the 62-day standard, that is above both Derbyshire and the Black Country. So recognising that during the pandemic, the cancer services were protected, to some extent that performance has been maintained and put us in good stead during that recovery phase. Finally, just touch on diagnostics. As I've mentioned, endoscopy is clearly an issue, and we've covered that. There are other areas of endoscopy other areas of diagnostics that are doing particularly well. Certainly we are well placed in terms of imaging, MRI, CT. Our areas of challenge are largely endoscopy. There are a few others, but they have got plans for recovery. Many of our trusts are insourcing additional capacity to clear backlogs, and there is a high level of confidence that some of those targets will be back on track. So the expectation in the national guidance is that we'll be back to 6 weeks by March 25, not 24 in this case. So it is expected that it will be another 18 months before they're fully recovered to the national standard of 6 weeks. But that sets out where we are now. And finally, just a point, I think you may have discussed this earlier, around the community diagnostic centres that are due to open. We have 3 within Staffordshire, the Tamworth, Cannock, and the large bespoke one in Stoke. So we expect the Tamworth and Cannock ones to be open for business this year, and the one in Stoke will be fully open in 2025. I'll pause there if that's okay, and take any questions.
Thank you, Mark. Let me bring in Janice.
Beat you to it, Keith. Thank you very much for that information. It's probably a joint question, to be fair, as I was just discussing with my colleague during that. And it's one that we've touched on already, which is about consistency and how we make sure that that's maintained. The part that I was focusing on in particular, and then I'll give way, was looking at how we've got the external review of the waiting list management at UHNM. I appreciate that it's a very fast-moving platform that's being looked at, but equally, how do we make sure that we have consistency in that regard? And then I'll give way.
Jenny's going to ask you. Just in terms of the 78 weeks, why there's nothing from the University Hospital of Stoke there? I can't see it on the list unless I've missed something out on that.
Okay, I'll do those in reverse because I think they're easier. There's a chart that sets out all those out-of-area providers that have got Staffordshire and Stoke-on-Trent patients that are waiting beyond 78 weeks. The paragraph underneath refers to UHNM. Currently has 312 reported in June, and then the trajectory for June, July and August. So those figures are in there, and then there's also the figures related to Nuffield, which are patients who have been transferred from UHNM into the independent sector. So hopefully that is included. In terms of consistency, I think I appreciate the valid point. The reason for the external review, UHNM to look at their processes, was because the numbers weren't coming down as expected, as seen elsewhere. So there was a general view that others had seen it, and it is for individual trusts to put their to put their own house in order. And clearly, UHNM took the view that it was best for them to get that external review to identify some of the issues of why their numbers weren't coming down as quickly as elsewhere. And as I say, that report identified a number of areas that are now being addressed. So hopefully that will bring back the consistency. And the GIRFT, not a phrase I like, the Getting It Right First Time team, is a national arrangement. And there is a link there where colleagues can have a look at it if they want to. But it is about sharing best practice. And this is really about how you get that consistency. And the GIRFT team do go around sort of sharing best learning and practice. And we have got 2 members of the national GIRFT team working with UHNM currently on improving their systems and processes. But it's not exclusive to UHNM. They work around all the trusts, but they give those that need additional help more time. So there are both national and local arrangements to improve the consistency in how waiting lists are managed. So hopefully that answers those 2 points. Thank you.
Sorry, my comment was more about the fact that it was left off the table in relation to others, and obviously the numbers far exceed the rest of the table put together from the other centres. So I don't understand why it would have been left out and just mentioned underneath the table as though it was separate in some way to the rest of the county.
Apologies for any confusion. I asked for a summary of those Staffordshire patients waiting outside of area, and that's what it is. That's that table that I've dropped in. Recognising that we are actively managed and by NHS England around our in-system performance, which is the UHNM numbers, but less so with the out of area. So to make sure we've got a full picture, I asked for a table of the out of area long waiters and dropped it into this report. Apologies for that, if that's caused some confusion.
Keith, have you got anything further you want to?
It's out. You say the table is out of area. Is that what you're saying? And the rest were all internal, or what? I just say the confusion continues.
So yeah, the table is out of area. It is Staffordshire and Stoke-on-Trent patients that are waiting beyond 78 weeks out of area.
So are you saying that none of the patients at the Stoke Hospital are out of area then?
No, they're part of the Staffordshire and Stoke-on-Trent system.
Well, there are residents.
So there are residents and part. So yeah. So the others are our residents too, but they're receiving care out of area. So they're receiving care outside of Staffordshire and Stoke-on-Trent.
I think we're clear on that. Janice, have you got any follow-up?
Well, it is reassuring to hear that the composition of the team, the getting it right first time team, I think is helpful in those. And any concerns that we have then with regards to potential postcode lotteries and that type of nature, I think it is always worth having a conversation about when we're looking at such matters. Thank you.
Thank you. Anne Edgeler.
Thank you, Chairman, and thank you, Mark, for your explanations and that. I've got two questions, but first of all, I want to say to you that of a conversation I had with a gentleman only a couple of weeks ago. His wife died of a cancer, a very rare form of blood cancer. He was only diagnosed in February, but he could not praise the work that the UHNM had given to his wife, and really, he was full of praise. And also I'd had a family member that had cancer treatments in the last 12 months. And again, I cannot fault that. But my two questions really relate to, first of all, you know, moving forward and with the strike of the junior doctors and consultation, the consultants, what impact is this have going to moving forward to bring the figures down? And also, can I also ask, why are we writing people off when they get to 75? And I'm thinking of bowel cancer and breast cancer. You know, they're not allowed to be have any investigation done, and surely that would help moving forward if we could, you know, have these people at 75 plus have these investigations done. I asked the question. Thank you.
Mark, we're with you.
Okay, thanks. In terms of the impact of the industrial action, it's clearly delayed some treatment. It hasn't had any other major difference, but what it has meant is that the trajectories that we had around recovery, the 78 and the 65-week waiters and so on, have been knocked back. Certainly, the consultant strike last week was quite impactful in terms of not only patients receiving surgical treatment and other interventions, but things like multidisciplinary team meetings where clinicians get together from a range of specialties to discuss the best care of patients. They will often consider a significant number of patients during one of those multidisciplinary team meetings, which were unfortunately cancelled as a result of that strike. I believe in one specialty it was about 80 patients were due for consideration. So clearly that's got to be rescheduled, and the ongoing care of those patients will therefore be affected. So I think we're all rather keen that the disputes around pay get settled as quickly as possible and we can get on to do the job we want to do. At the moment, we don't know what further impacts we're likely to have. It does mean that every time there's a strike, there is a re-evaluation of the trajectories around recovery. But all I can say to the committee is that we need to please be assured that people are doing what they can. Those highest priority patients that have been waiting longest are being rescheduled as soon as possible. But as I say, we don't yet know what further industrial action there may be and how long it will go on for and what the consequences might be. In terms of the second question, I'm not sure I recognise the position. The screening for cancers is set nationally and the local ICB doesn't determine that. So if you're referring about, if you're making comment about the national screening programme that seeks to identify cancer early in the population, I'm afraid I'm not in a position to comment on that. And in terms of people with symptomatic presentations, then they will be investigated for cancers accordingly, irrespective of their age. So I may have missed the point, but I'm not sure I can comment further. But please come back if I've misrepresented what I've heard.
So, Mark, are you saying in terms of it's the pre-screening, so advanced screening will be done under 75 and post-75, there is still investigative work done? Is that what you're saying?
If a patient presents and is believed to have cancer symptoms, they will have all the usual investigations and be treated accordingly. Nobody is written off irrespective of age. And I don't recognise the point that was made. If there are cut-offs within the national screening programme, I'm afraid we don't commission that and I couldn't comment.
Oh, thank you for that, Mark. You know, I understand what you're actually saying, but is there any pressure that you can put on anyone that can bring any screening back into being for over 75s? Because people are living longer now, but it's recognised once you get to 75, you're off the cliff, and nobody, you know, where it would probably help the health situation if they are diagnosed earlier. Thank you.
Absolutely, I couldn't agree more. I mean, one of the indicators that we have around cancer that is, I wouldn't so much been suggested has been parked, but it's sort of been put to one side at the moment, is about early diagnosis. We've got to do better around early diagnosis, and you're quite right. I would welcome that. But the other thing I would add, though, that there are wider areas to tackle than just age. We know an awful lot of people that are entitled to the screening programme as it is now don't take it up. And we've got to do a lot of work around that, because that is really important, as well as the age issue, is about this poor percentage of our population that don't take up screening opportunities. If we are serious about tackling cancer and tackling cancer early and getting those earlier diagnosis to get better outcomes for patients, then we do need people to attend when they are offered their screening opportunities. It isn't new. It's been going on for years. I think the pandemic sort of made it slightly worse. But yeah, I appreciate the point about pushing nationally to get wider screening opportunities. But what we also need to do is get people to take up those screening opportunities that are there, because the uptake isn't as good as it should be.
And obviously your other message is if someone feels unwell, they should immediately go and contact their primary care doctor and have an investigation.
Absolutely.
Okay, understand that. Thank you. So let me bring in Chris.
Yes, thank you, Chair. The NHS is extremely good at analysing delays. They're very good at counting numbers in that respect. What they're less good at is having a similarly detailed analysis of the impact on the experience and outcomes for patients, particularly in the longer term and in terms of their mental health and anxiety levels. And I think that is also missing here at the moment. And what I would say is, having talked to a number of patients who've been through this, is that if there are delays, and there are significant delays, the importance of good communication in a form that is accessible to the patient is really important right throughout that delay process. And don't leave people dangling, is what I would say, and unfortunately it happens far too often. I would also talk, Chair, about the importance of reliable administration. If you do something when you say you're going to do it and in the way you say you're going to do it, and then people get assurance from that they haven't simply been ignored and lost in the system. Thank you, Chair.
And presumably, in particular, when there is cancellations of elective work, when there are outside factors like strikes, presumably.
Yes, there is that, and we've also had people waiting very long periods of time for potential stage 4 cancer diagnoses. And we've had people who've been referred from GPs to hospitals, and almost a quarter of referrals from GPs to hospitals go missing. It's called the referrals black hole, and there are national reports on it. So there's a whole series of issues there about not leaving people in the dark without information when they have potentially serious illness.
Thank you. Mark, we're with you.
I don't think I disagree with any of that. You're absolutely right. We absolutely need to communicate better. I think things have improved. I think if we are being fair, the impacts of the pandemic were new, and we've all had to learn a new way of working. And I would be reasonably honest and say I don't think communication was as good as it should have been when we first started dealing with the backlogs, but it is getting better. All our trusts undertake harm reviews of long waiters, and patients are reviewed on a minimum of 12 weekly basis that are on those waiting lists. So I think it is getting better. The frustration, which I guess we all share, is that patients can still at times having cancellations. So they'll get a date for their long-awaited surgery or appointment that then may still be subject to cancellation through whatever factors may influence it, be it nurses' strike, junior doctor strike, or consultant strikes, or increasing demand in urgent care. There's a whole raft of reasons why things can go wrong. It is frustrating, but I think we are getting better at it. But yeah, we need to continue to learn and continue to adapt. And I would not disagree with anything the speaker just said.
Thank you. I think that's comprehensive. So thank you, Mark. Just one question from me, and then I'd like to wrap up this session. I just make sort of the point that, a 5-year wait for someone on elective surgery is, that for many will be a very worrying date or number that you put in people's minds. And, if I was on the end of that queue, I'd be really concerned. I guess my point really is not about that. It's just reflecting on that. I guess my point really relates to, it looks like the sort of, it's in the specialities where the backlogs now, the longer backlogs, are sitting. For example, in colorectal cancer, running at 35%. So there's obviously a huge backlog there. And I wonder whether actually, are we looking wide enough in the region for those speciality areas, i.e. Are we focusing only on the system, Staffordshire and Stoke-on-Trent, when actually probably many other systems will have similar backlogs in similar specialities, and whether actually we needed a more joined up regional approach to making a better impact. I focus on, if you look for a solution which is, I want 10% more from a system, and you can drive 8%, well, that's great. But actually, if you want 100% more improvement, you come up with a completely different way of working. And please don't focus on the numbers, but the point is, you'd find a different way of working. And I wonder whether we've focused enough on the specialities and found a different way of working across the region to find a better solution that brings those delays to elective surgery down quicker.
Yeah, really good question, and I think there's two or three parts I'd like to answer in detail. The proposal that it might take 5 years to recover to what might be acceptable levels of elective care doesn't mean to say individual patients will be waiting 5 years. And apologies if I gave that impression. What we are seeing nationally, as I've mentioned, is that we need to eliminate people waiting beyond 65 weeks by the end of March. Now, presumably there'll be a further target for March 25, which may be reduce people waiting beyond 52 weeks. Then the year after, perhaps 36 weeks. So what I'm saying is to get back to what we had previously, which was between 18 and 26 weeks, typically pre-pandemic. That's going to take 4 to 5 years. That's not the same as people waiting individually 5 years for treatment. So hopefully we've clarified that. In terms of cancer, there is already, and historically was prior to the pandemic, a mutual aid arrangement for people with cancer. A cancer hub was established during the pandemic to make sure that people awaiting cancer surgery could be referred elsewhere using a mutual aid arrangement, and that continues to exist. Many areas are struggling with the same issues, and separating out some of the cancer work from non-cancer work is key to delivering a better cancer performance, and certainly the fact that endoscopy, for example, is crucial to both cancer diagnosis and serious bowel disease that's non-cancerous. Having pressures in that area are a real problem, both within the system and outside. And we understand the reasons why, but it's going to take time for the system to adjust to allow us to make up the gap. And just to explain very briefly, part of the reason why we've lost productivity in endoscopy is because there's greater infection prevention control measures now in place as a result of the pandemic, and there's other measures that mean things are a bit slower, so you can't do quite as much work as you used to within the same facilities. We have got built-in additional endoscopy capacity coming into the CDCs, which hopefully will help us, but we're just going to get over that hurdle of getting there until they're open. But yes, there is absolutely mutual aid support across the systems. One of those 104-week waiters I mentioned to you is awaiting treatment in Nottingham. So there is quite an effective arrangement around mutual aid. As I say, part of our problem has been unexpectedly, patients seem to be less willing to transfer to a different provider now. Having waited go back pre-pandemic, we were offering patients alternative treatment after 26 weeks, and a lot of people were choosing to take that option. Now we're finding that people who've been waiting 2 years are thinking, well, might as well stay where I am. So we're finding an increased reluctance for people to travel. We certainly offered a lot of people treatment in other centres over the last 6 months or so, and a lot of them said no. So as a result of that, that's probably where we are with some of our long waiters. But please be assured, certainly across the Midlands, and certainly Staffordshire and Shropshire do collaborate very widely, and Staffordshire and the Black Country collaborate very widely on cancer patients waiting treatment. So yeah, please be assured on that front.
Thank you, Mark. That's really helpful. It's clear that you enjoy what you're doing, and you brought that insight as well as passion to today's discussion. So I appreciate the work that you're doing. And Mark, thank you, and Phil, for that report. It's not all welcome news, but at least there is a plan, and you're doing the best with the resources you got, from what I can see at least. Is that the view of committee? Yep. So, Mark, we will thank you, and Phil, for your interventions this morning, and we'll hand over to Mish. Mish, we are looking to finish at 1. I would suggest you have 50 pages of lots of really good stuff in there, as ever. Maybe you could take 5 minutes, and then we'll just open up to questions. I know you've got probably an hour or two's worth of stuff. If we need to handle this in a different way another day, then happy to do so. It's a really key issue, given vacancy levels within the NHS. So we're in your hands, certainly for the next 5 minutes.
Thank you. And on that basis, I was going to share just a few slides with you, and to show you Ola's story. So I would, if I could, encourage colleagues outside of the meeting to watch Ola's story. She's a Ukrainian refugee who's a cardiologist. She's come to live in Staffordshire and Stoke-on-Trent, and we've supported her as part of our overall collaborative approach to get some time working at the hospital, and we're hoping that we'll be able to welcome her into our medical workforce. So that's the only thing I'd say about the slides. But before I start, just to introduce myself to colleagues that I haven't met before, I'm Mish Irvine. I'm the ICS Director of People for our system. My colleague has joined me today, Gemma Traynor. She's the head of the programme. So together we'll be answering your questions today. So I suppose just in terms of why we're here today is we wanted to give you an interim position, really, in terms of where we're at, what our main challenges are, and where we have made some achievements over the last year. We wanted to talk to you about that and answer your questions. It is a truly collaborative approach in Staffordshire and Stoke-on-Trent. We have representation in all of the groups, and you'll have seen those groups in the report and also in the slide deck, that actually deliver the workforce initiatives across the system. Now, our biggest risks are retention, health and well-being, our vacancy factor, as Jeremy's mentioned, but also the industrial action that we're currently facing at the moment. We have got an increasingly pressured workforce, so we've heard about all of our operational pressures. So pulling together our workforce in a way in which they feel valued, in a way in which they feel listened to, and also that we collaborate across our organisational boundaries is probably the only way that we're going to be more efficient and effective as well. So we have representatives from our NHS workforce, from our social care, from our voluntary sector, in all, and primary care as well, in all of our groups. So we do genuinely collaborate. The leadership model is one where the chief people officers from the NHS, trusts and social care do work together to lead on and to push forward and develop the initiatives that make sense for them. So really, it was to talk to you very briefly about that. You've seen that we have an annual report. There's lots in there in terms of achievements. There's been a lot of conversation this morning about KPIs. So we do measure our KPIs within the workforce remit. Our vacancy levels at the moment are 12.9% in May. Now, that is too high. I'm sure you'll all agree. And we are trying to tackle that via the methodology that we've described in the report to you and our collaborative approach. The better news is that our turnover is 10% now, which has decreased. And also we have got some progress in terms of our sickness. So that was really quite significantly higher than the 4.4% that it is now. I'm referring only to the NHS data when I talk to you about this. And that is, again, another area that we're trying to improve our data collection so that we have our social care workforce within there as well, so we can talk the same language and really focus our efforts based on an evidence-based approach. So, Jeremy, I'm going to stop there because you have had a lot of information from us and I'm sure you've got lots of questions, so I would like to give you the opportunity to ask us.
Thanks, Mish. I appreciate that. And as you rightly say, there's a huge amount of stuff in there. I also omitted to mention that committee will, you're coming back to committee in October from memory, if only just to talk a bit about some of that ongoing progression, particularly in terms of social care. And can I just get this right? The numbers you just talked about are just within the NHS yes. across the system, but don't include social care. But obviously we have seen some reference earlier that within the employee hub you're doing work which includes social care as well.
Yeah, I mean, this is something that's a national issue in terms of data collection. Unfortunately, we do speak a different language when we're talking about counting. So what we are doing as a pilot within our system is actually working with Skills for Care to try and translate the data that they have in enabling us to add it on in a very accurate way, because, you know, you could actually amalgamate that stuff and it doesn't really mean anything and it may be entirely inaccurate. So we are doing that at the moment, but at the moment, sadly, our data sets are separate. And just to mention, around October, we will have our CPOs from the organisations joining us at that meeting. So it will be an update on progress. We'll be able to talk to you about our KPIs a little bit more robustly because we'll have had a bit more time to do the social care work. But our CPOs will be here from the organisations to answer specific detailed questions if you have them.
Yeah, I think you make a really good point because I think from memory the social care figure was closer to 30-odd%. And if you're not careful, you find that one set of figures dwarf another, and you miss the impact that you have as a system. I'm not seeing any indications yet, so I'm just going to carry on. On your I will give way and let Janice Sylvester Hall come in.
Thank you, Chair. The amount of information in here I think is fantastic, and trying to look and see what is delivering the impact I think is probably where a high level approach, so the headline figures that you just gave us there is helpful, and the long-term workforce plan I thought as well was a very powerful one-pager actually. The part that I would like to just highlight is something that I'm particularly keen on. It's the journey to work. I did watch Ola's story, by the way, just so as you know. And I think when we look at what we are doing to try and bring young people, so in other capacities, we always refer to grow your own. And certainly having had the opportunity to sit on this committee and work with other neighbouring providers has been insightful too. And I think that sharing of the best practice is key. But equally, what we do with our young people to give them an insight into want to consider taking up a profession in healthcare in whatever capacity. So I was particularly keen to look at what you're doing in Key Stage 1, Key Stage 2, Key Stage 3. Do we have opportunity where these young people can actually still come in and have a work experience process?
Yes.
I appreciate that a lot of the time, and I work with businesses and all sorts of things that are under extreme pressure to deliver, to perform, but taking the time out to give young people that insight is, I often find, time extremely well spent. We may not appreciate it at the time, but certainly in the future. So just as a quick question, but as I said, I do appreciate the content and the detail in here. Thank you.
Thank you. And thank you for mentioning the long-term workforce plan as well. So that we managed to consolidate 150 pages onto that one slide so that we could really focus our efforts and articulate the ask in that plan. And the plan is very robust. However, I think quite rightly, they've decided to leave it open for local interpretation in terms of what does this mean for us. So it does articulate how we will try to have more workforce over the next, say, 10, 15 years. But where we are right now is that linked to the journey to work, we have to incentivise our local children and also those that are working. You know, the journey to work, if you noticed in the kind of the annual report, it's not just about the young people and our school age kids. It's actually about people who are working in different careers, those from our seldom heard communities as well. But very specifically on the work experience, I'm going to bring Gemma in. I mean, I could talk for hours on it, but I think Gemma needs to have that opportunity because this is something that herself and the team have worked really hard on. And we've got a number of different work experience opportunities all linked to Journey to Work. Thanks, Gem.
Thanks, Mish, and thanks, Janice, for bringing that up. It's one of our really passionate projects that the team have been working really hard on over the last sort of 8 to 9 months. And it was definitely something that we'd spotted was a gap in terms of us reaching out to our communities, but specifically in terms of promoting health and care careers. But the other thing that we're trying to do through the project is raise the aspirations of young people. So that's sort of the premise of the project, but also spotted an opportunity through COVID to introduce the virtual work experience to prevent us from losing the opportunity of young people and adults from gaining work experience in health and care. So we've got a range of programmes there in the report. What we have been recognising lately is through conversations with schools that the teachers are really keen for the young people to get back into schools, and we're really keen to have them come in again. The virtual work experience has created lots of opportunities for us to offer careers information to more young people and adults, but we do want to get back to that physical work experience as well. So our next phase of that project that we're planning at the moment actually will explore a virtual a work experience portal where we'll kind of centralise the process for inviting young people into and streamlining the process for young people coming in on work experience.
So almost using the virtual work experience as an initial assessment so that individuals can go through that. They can undertake the assessment, they can see actually, is this for me? And then what we're doing then is to move them forward into a physical work experience placement, which will hopefully then incentivise them to take up one of our apprenticeship roles. So that's kind of the journey that we're trying to create.
Janice.
Yeah, just very quickly, that is music to my ears to hear those particular initiatives that are going through. And equally, that we're going to be revisiting this because I think that seeing the impact of the content of that will be, very useful. Thank you.
Thank you.
And the only real question I had was how do you keep all of that up to date with the sheer volume of stuff? But, you know, that's a different question for a different day. But it's maybe a challenge we'll just leave with you on the table whilst we bring in Charlotte. Charlotte Atkins.
Yes, I wanted to ask you about your apprenticeship programme. Over what sort of roles are you using apprenticeships, and hopefully right across the whole range of roles? Are you finding that apprenticeships open up new areas of cohorts, and how are you developing the apprenticeship programme to ensure that you do get that diversity of intake, which perhaps you haven't had before?
Thank you. Thank you so much for that question. We've got a number of system-wide apprenticeships and numerous apprenticeships in the individual providers. I'll talk about the system ones because they're the ones that we are trying to create diversity, both in terms of experience, so the placement location, people work within the NHS social care into primary care, so they do rotate. We've got the general apprenticeship scheme, which is a healthcare assistant apprenticeship, which then leads on to a nurse apprenticeship. We then have the pharmacy tech apprenticeship, and there was a lot of discussion about pharmacy at the start of this meeting, which links into the additional roles and responsibilities in primary care, trying to increase our supply of workforce. And our most recent system-wide apprenticeship has been the physician's associate, which is again an R's role, and we'll be working in partnership with GPs to try and increase the skill mix within primary care and release GPs to do work that's more appropriate for the more complex patients. In terms of the way that we've adapted it, so we're on our 5th cohort now of our healthcare support worker apprenticeship, and when we first developed it, we did go to a college and we liaised with a number of students that were doing their level 2, and we recruited from there. And we did see that there was a very specific demographic, and what we wanted to do was increase the diversity from both the seldom heard communities, but also in terms of those individuals who may not have had the educational attainment to think that the NHS and care was for them. So what we've done is we've worked really closely with the YMCA. We've worked with Stoke College in terms of developing a traineeship. So now, out of those that are starting in September, I think there are about 3 or 4, and we have got, and I think we showed the video last time, we have got a number of individuals from the previous cohorts that are either refugees, individuals from ethnically diverse communities who wouldn't necessarily have thought that this was something for them. And we've also put them through traineeships, so they haven't had the 5 GCSEs at A to C, using the language that I understand. I think it's numbers now, but they didn't have that. So we've actually helped them to pass their math and English, and now they're in our workforce and talking to their communities about that. So we're really proud of that work, and the YMCA have been absolutely instrumental. We're also working with an organisation that works specifically with care leavers. So again, to try and target our approach so that we change what we do to help colleagues come into us, rather than expecting those colleagues to be what we traditionally may have been perceived to need.
Are you also using apprenticeships for perhaps not just the young workforce, but other people who are perhaps thinking about changing course?
Absolutely. So that's part of the journey to work. There's a few phases there. One of them is about the job centre approach. So Gemma's team go into the job centre on a regular basis. We also target our publicity and our recruitment campaigns to show that, you know, regardless of what you have or what you've done in the past, there is a route into working into health and care. So that links to the earlier conversation about the people hub, the reserves, the social care roles that I referred to earlier. These are all people who have been living and working, that they're not young people, they're people that have been living and working in our population that have changed their career because they've realised that actually they have the values, and for us that's what we need, the values of the people to come in and work for us, the training, the experience we can sort out for them, and actually also the transport, because the driving licence thing has been a major issue. So we've actually been transporting people to certain home care facilities to help them get to work, and that then leads into the apprenticeship route. So we're trying to do as much as we can to amend our approach. So there's the short term and then the longer term piece, including the journey to work as well.
Thank you. That was a really comprehensive answer, probably backed up by the comprehensive papers that we've got in front of us. And just sort of falling off the back of that, I mean, one comment I had in terms of the apprenticeships was whether you've got a sort of a willing network of mentors who are supporting those apprentices, maybe of different ages and experience within the system, because often, you know, the questions you don't want to ask your colleagues and peers, you can ask, ask of a mentor and get a better better idea. And I also, picking up Charlotte's point as well, looked at the retention strategy and wondered whether there was sufficient in terms, not sufficient, whether there were other options in terms of flexible returns for those people who've left either post-family or post-retirement, because often people have different ideas later, sort of a year or two later as time goes by. And obviously the career development point just needs to be making sure it's system-wide across health and care to make sure that we've improved people's skills to a maximum and their expertise. So not only are they more fulfilled, but they also can give back more as well at the same stage. Maybe those are conversations for a different day, and maybe we'll just think and reflect how best to get the workforce piece in October, just bring it to life. Not that these pages haven't, but it's just there's a lot there, and we probably just need to see where the focus is that we want to pick up. Does anyone else have any questions for Mish? I think, Mish, whilst it's only been a very sort of short period for you and for Gemma, there's clearly been a lot of work, and it's really pleasing to see. Often in this committee, it wants more from the workforce than we see because it's such a key issue for the whole of the system. I have to say this looks like a very comprehensive plan and takes in an element of the individuals you're trying to engage with as well, and it feels very sort of employee-centric as well, and I think it has much more chance of being delivered because of that. So certainly from my perspective, I thought it was very comprehensive and really interesting, and maybe we just need to reflect outside of this how we bring you back to committee and get sort of some of this plan to come to life so that members can interrogate it, but maybe add value to what you've done as well.
Thank you.
Thank you. I've got lots of nods here, Mish, so I think everyone is if not in agreement with everything I said, at least the sort of the direction of travel. So thank you for that, and thank you for staying with us for all of 3 hours, so I appreciate that. And thanks to the work that you and the team and Gemma is doing as well on that. In which case, please stay, please go. We will move on to item number 9, which is the work programme. We've added to the work programme today. We will come back to you on the next agenda with where those fit in. We may need to juggle around with the work programme, and there is a lot of work going on. So apologies, we have another meeting next week. It is on adult social care and giving members a good, clear understanding of the brief of that and the breadth of it. We will be having a CQC a CQC visit later in the year, early next year, for social care and having members up to speed with what that might look like and all the relevant areas is useful. I would say, given we've got 2 meetings in a week, I think you'll get more out of it by coming in person. My personal view, you will get more out of it by coming in person. It is a formal meeting, but I would accept for a small number of people, particularly those furthest away, particularly those people who might otherwise not be able to attend virtually. So please don't all take that as a carte blanche not to turn up. Otherwise, you'll give me minor heart palpitations before we start the meeting. Because if we're not quorate, we can't carry on. So please just be very mindful of that. But for those who are furthest away or those who would otherwise not be able to attend, please consider that. I expect the meeting to be about 90 minutes. It's being led by Dr. Richard Harling. I will say very few words, I promise. And then after that, our next meeting is in September the 11th. I think we've worked that out. In the meantime, there are various virtual and physical face-to-face meetings. I think we've reconstituted the women's group under Janice Sylvester Hall. You know who you're on it. We will circulate that as part of the minutes if you don't. If you're unclear, please contact Zach. We've also reconstituted post the local elections in May the Integrated Care Hub Working Group. Sorry, I can see you're not on here, but maybe we'll find some way of making sure you're tied into the communication, if not the working group. That's now being reconstituted under Richard Cox. There are a couple of meetings in August and September. Outside of that, there's some reference site visits. We're still trying to get the terms and frames of reference for the, this is following the quality accounts. People who attended the quality accounts meetings might remember that we had North Staffs Combined and Midlands Partnership Foundation Trust in, and we said we're going to have some physical site visits. I don't suggest we cannot take 21 committee members to the site visits, so we're going to try and reduce that down to a small number or a smaller number. So we'll circulate those dates in September, see who A is interested, and B, based on a capacity, who would be most sensible to attend those. And there's also a deep dive on adult social care workforce, which is something we agreed to put in the diary. It's in the diary for mid-August, but I guess if it's not in the work programme plan, that we probably need to identify who would like or benefit most to come to those meetings, accepting people might have holidays, and it's quite a heavy agenda and timetable at this moment. Does anyone want to interrogate that in more detail? If not, I'm going to wish you a good afternoon. Thanks for bearing with 3 hours. I know it's tight and tough work, but appreciate that, and I'm sure our residents will as well. Have a good afternoon.